Good morning, everyone. The subcommittee will now come to order. We're meeting today to consider 10 healthcare bills. And I will now recognize myself for 5 minutes for an opening statement. Good morning, everyone. So today our subcommittee marks up 10 bipartisan bills to improve the health care of families across the country. Subcommittee members have worked very hard together to tackle difficult problems around the issue of surprise billing, drug pricing, and critical public health programs. And with today's markup, we're going to continue the progress so that Americans can afford their health care and receive it in their communities in a manner that is worthy of them. We'll need to keep up this momentum. Unfortunately, 2 days ago, President Trump and Republican attorneys general fought in court to strike down the entire ACA. This court case is the latest in a near decade-long fight to end protections for people with pre-existing conditions, taking health care away from over 21 million Americans who receive their coverage through the marketplaces or through the expansion of Medicaid. And it would obviously strip young adults of their coverage through their parents' plans and return to lifetime and annual caps on benefits. It doesn't have to be this way. Our subcommittee has been able to find common ground on bipartisan bills that will help Americans access and afford quality health care in 3 major ways. First, we're marking up bills that will invest in our healthcare infrastructure and workforce to address physician shortages and strengthen access to care in communities across the country. The Empower for Health Act and the Title VII Nursing Workforce Reauthorization Act reauthorizes healthcare workforce development grants for 5 more years. I think that that's very important. The Autism Cares Act, the Newborn Screening Saves Lives Act, the Emergency Medical Services for Children's Act, and the Lifespan Respite Care Act allow very important public health programs to continue to improve care for Americans across the course of their lifetimes, and that is being extended for 5 more years. 2328 is the Community Health Investment, Modernization, and Excellence Act, and its expected amendments reauthorizes for 4 years. These are crucial healthcare programs that our communities rely on, such as community health centers. And I don't think there's a member here that doesn't celebrate their community health center. Every member knows to the gnat's eyebrow what they do and how important they are. The National Health Service Corps, the Teaching Health Center Graduate Medical Education Program, and the Special Diabetes Program. 2328 and its expected amendments will also strengthen DSH, the disproportionate share hospitals that serve lower-income Americans, and it improves the Medicare program through stronger enrollment support and help for low-income beneficiaries. And we all have those low-income beneficiaries in each one of our districts. Next, we're marking up legislation to lower the price of prescription drugs. The Fair Drug Pricing Act and its expected amendments will shine a light on the inner workings of drug companies and the PBMs. It will require drug manufacturers to justify large spikes in drug prices, which is real sticker shock for all of our constituents, and require PBMs to report the discounts they negotiate with drug manufacturers. These are transparency measures, and they're going to help. It doesn't cure all of the ills in the system, but these transparency measures will help to ensure that patients are getting a better price for their drugs. Finally, we're marking up Chairman Pallone and Ranking Member Walden's No Surprises Act, and no surprise, to end surprise medical bills from out-of-network providers. At our hearing on surprise billing, we heard every witness support, quote, taking the patient out of it. And we also heard from Sanji Wilkes, who is still suffering from a 15-year-old surprise bill from her son's stay in an out-of-network NICU. She had three words for us, get this done. So the time has come for the egregious practices of surprise billing to stop. As with any meaningful legislation, there's a spirited debate about the best approach. And I'm sure we're going to debate today, but let's not lose sight of the need to get this done. I'm so proud of our subcommittee's work to reach bipartisan agreement on the must-pass bills we're marking up, and I look forward to working with each member to continue this progress. I now would like to recognize Dr. Burgess, the ranking member of the subcommittee, for 5 minutes for his opening statement.
I thank you for the recognition and acknowledge that it is critical that we are here today, marking up extender and reauthorization policies to maximize the chance of them becoming law prior to their expiration at the end of the fiscal year, which is September 30th. As I've said before, reauthorizing these programs in a timely manner is imperative. Once these bills advance through the full Committee of Energy and Commerce, I hope that we can, in a bipartisan fashion, communicate to the Speaker and our respective leadership how important and bipartisan these reauthorizations are. Community health centers, teaching health centers, and the special diabetes programs, the family-to-family health information centers, are programs that make a real impact in providing access to health care for Americans. In fact, just yesterday, I met with two young members of the Juvenile Diabetes Research Foundation Children's Congress. They're delegates from North Texas who are living proof of how important the special diabetes program for type 1 diabetes is. And I know that the advocates have been making their voices heard throughout this process, and certainly today, I'm grateful that we're advancing these public health reauthorizations to the full committee. I appreciate the inclusion of the Empower for Health Act, which will reauthorize Title VII physician and other health professionals' workforce funding. When I was chairman of the Health Subcommittee in the last Congress, we moved both Title VII and Title VIII reauthorizations through the committee and indeed through the House. Unfortunately, the Senate did not take up either of our bills, and perhaps with a big vote in passage, we can help them understand that they should have some interest in reauthorizing these vital programs this year. The Medicare Extenders package before us today also includes a number of priorities that will benefit our Medicare patients across the nation. I especially appreciate the inclusion of a 3-year extension of the Independence at Home demonstration, which I've championed with Representative Debbie Dingell. I welcome the opportunity to work with her once again on this priority. Following up on the groundwork Republicans laid in the Bipartisan Budget Act of 2018 in delaying disproportionate share hospital cuts, one amendment before us today includes a buyout of DSH cuts for 2 years. My fellow Texan, Representative Pete Olson, introduced a similar bill, and our local hospitals in Texas and across the country will benefit from this policy. We also have authorizations of Medicaid funding for the United States territories, including Puerto Rico, the United States Virgin Islands, Guam, and the Northern Mariana Islands. As we heard from our witnesses at our hearing, we know that the American citizens who live in the territories disproportionately rely upon the Medicaid program. But as I noted in our hearing, Congress needs to know how these dollars are being spent so that we are good stewards of taxpayer dollars. I also welcomed it when we heard that the territories could implement a number of program integrity measures to ensure protection. We don't want dollars to be spent in an inefficient, duplicative, or an unlawful fashion. This bill would require the territories to implement certain tools to do just that. Given the disappointing news out of Puerto Rico just yesterday, I think we can all agree that more can be done, and I certainly look forward to conversations with committee members and our staff are already having to put additional measures in place before this bill arrives at the full committee. This committee has put a lot of effort into building off the transparency package that moved through the Ways and Means Committee. Members on both sides of our dais exhibited interest in improving the legislation to make it workable and protect against unintended consequences. I appreciate the willingness to work in a bipartisan manner to get this bill where it is today. I can say that the majority listened to our concerns, and I support the bill that we are considering, and I urge all members to do so. I want to thank the chairs and their staff for taking this issue through regular order and doing the hard work to get us where we are today. Lastly, we are considering the No Surprises Act, which would outlaw surprise or out-of-network billing. This has been a bipartisan effort from the start, and I hope we can achieve consensus. I certainly want to thank the chairman of the full committee, Mr. Pallone, for his introduction of the language that we're going to be considering today. I want to thank the White House because they've made this a priority, and I think there is a broad consensus, House, Senate, and White House, that the ultimate goal is to remove the patient from the middle of this any dispute that might occur. I do appreciate the good faith efforts that have been made to work toward a compromise thus far, and I hope that such efforts will continue following the subcommittee markup and that we will achieve a true solution before we finish in the full committee's work. I'm glad we've achieved agreements on the must-pass priorities before us this morning. Thank you, Madam Chairman. I'll yield back.
I thank Dr. Burgess. I now recognize Mr. Pallone, the chairman of the full committee, for 5 minutes for his opening statement.
Thank you, Chairwoman Eshoo. Let me say, start out by saying we are continuing with this committee's work today of putting consumers first, expanding access to health care, and making both prescription drugs and health care more affordable. And the 10 bipartisan bills we're marking up today will take a great deal of strides towards achieving those goals. I want to thank, first of all, I do want to thank Ms. Eshoo, our chairwoman, Dr. Burgess, the ranking member, and all the staff for working so hard to make this markup possible, in a bipartisan fashion. And of course, I want to thank our ranking member, Walden, for all his work on many of the bills, particularly the surprise billing. I should mention also, Madam Chair, that, it's not only our committee, it's also the fact that, for the most part, these bills have Senate counterparts, and we've been working on a bipartisan basis with the Senate as well, and with the President. So I think, for the most part, these bills are likely to become law. These are not message documents today. This is the real thing that is worked on with the Senate and with the White House, and I think most of the things that you see here today will ultimately become law. And so that's significant. It shows the bipartisan nature of the committee and also the bicameral nature of what we're doing. The process has always been to keep the patient and the consumer at the center, and so I'm also proud of that. I wanted to mention, Madam Chair, also that Jeff Carroll's daughter Lizzie is here today at the desk. She's helping us, sort of a day intern. I think everyone would recognize the resemblance. I don't have to mention that. We've said that before. So what have we done? We've negotiated a 4-year extension of our expiring public health programs. We've tackled the difficult problem of surprise billing, and we've also reached a long-term funding agreement for the Medicaid programs for Puerto Rico and the U.S. territories. Not permanent, we're still working on that, but from 4 to 6 years, which is the longest I think that we've ever had in terms of any kind of extension for those Medicaid programs for Puerto Rico and the territories. Today we'll consider the No Surprises Act, which I introduced with Ranking Member Walden to address the issue of surprise medical billing. Our legislation removes the surprise from billing by completely protecting patients in emergency situations, patients who did not specifically choose to see an out-of-network physician for scheduled care, and patients in situations where there is no in-network provider available to treat them. This legislation protects consumers, and it does it without raising health care costs for working Americans. It's critical that we pass this legislation today and finally protect patients from these outrageous surprise medical bills. The subcommittee will also mark a number of bills to improve the Medicare program and reauthorize vital public health programs that strengthen the health care workforce and provide direct access to health care for American families. the Title VIII Nursing Workforce Reauthorization Act, introduced by Representative Joyce, and the Empower for Health Act, introduced by Representative Schakowsky, will ensure that our nurses, doctors, and allied health professionals receive the training and support they need to be the strong, stable, and diverse workforce. The subcommittee will also strengthen a number of public health programs that will expire at the end of this fiscal year. Representative O'Halloran's Community Health Innovation, Modernization, and Excellence Act will provide community health centers and the National Health Service Corps with a historic level of funding. And this bill will extend the programs for the longest period since the Community Health Center Fund was created in the Affordable Care Act. We'll also consider an amendment in the nature of a substitute to the package offered by Representative Butterfield that will incorporate long-term extensions of several other health programs, including the Teaching Health Center Graduate Medical Education Program. We've also acted decisively to address the dire humanitarian crisis looming in the territories. Today, we'll consider a bipartisan bill that will provide 4 years of additional funds and an enhanced matching rate to Puerto Rico, and 6 years of additional funds and enhanced matching rates to the U.S. Virgin Islands, American Samoa, the Northern Marianas. We'll also consider an amendment that will provide 2 years of responsible relief to the pending reductions to the disproportionate share hospital payments, or DSH, and we're also considering the Fair Drug Pricing Act, as well as an amendment in the nature of a substitute with other provisions that will increase drug pricing transparency. This legislation will ensure consumers have access to more information about how prescription drugs are priced and why drug prices are increasing. So again, all 10 of these bipartisan bills are good. I look forward to sending them to full committee, markup next week. And again, I want to thank you, Madam Chair, for your leadership and your continued commitment to moving these bills through the subcommittee and all that you've done. Thank you, Madam Chair.
The gentleman yields back, and I thank you for your kind comments. The chair now recognizes the ranking member of the full committee, Mr. Walden.
Thank you, Madam
for
Chair.
his 5 minutes.
And as you can see, it's been a tough negotiation, but we've worked our way through it. Hopefully it's not that hard when we get to full. I think we've heard about the bills we'll be marking up. I just want to say how important they are. Many of these are the extenders we did the last Congress, and I'm really pleased, especially for community health centers. They're going to get additional years of support. That's been a big priority of mine. And these other measures are really important as well. And I know we have additional work to do between now and the full committee on some pretty important issues. And we think, I think there's paths forward on all of these. On the Medicare front, the package, of course, includes the HEARTS Act, championed by former Representative Sam Johnson. That would protect severely wounded veterans from facing a Medicare Part B premium penalty if they're able to rejoin the workforce. Also included is a policy championed by Dr. Bouchon and Mr. Rush to improve the diagnosis of prostate cancer, to assure providers and patients are being informed correctly. It's really important. And I want to note the extension of the Independence at Home project, championed by Dr. Burgess and Representative Dingell. And it also includes an important Medicare fix I've heard a lot about from patients firsthand. I met a young man named Archer who who relied on a complex power wheelchair for his daily life because of his cerebral palsy. I was thrilled to tell him last year that with Congress's support, access to chairs like his would be maintained. And this committee's really led on this issue, working to fix the issue for power chairs, passing a resolution on this problem on the floor last year. And today we continue to show our commitment through inclusion of this policy. Finally, our amendment to the base package will address the disproportionate share hospital cuts over the next 2 years. This 2-year window will give us time to figure out how best to update the DSH formula and address the cuts moving forward. And I know we've got other measures that are in here as well. But in the No Surprises Act, I want to thank Chairman Pallone for his leadership on that and working with me on this. I think we all agree that the patient needs to be taken out of the middle. I met with a group yesterday and said, I'm not quite sure why this landed in our lap to begin with, but when consumers are getting harmed, we're going to step up and do our best to solve the problem, and that we will. And it will become law at some point. So we are not going to allow these crippling financial bills to be foisted on consumers. I hearken back to our witness who had the son diagnosed with hemophilia, and I got a $50,000 bill because the NICS unit in the hospital that was under her plan had been contracted out to somebody else. And I can't imagine as a father that that's the first thing you'd ask the doctor, is your neonatal intensive care unit under my insurance, if your whole hospital is supposed to be. This is the kind of crap that needs to stop, and we're going to put an end to it. So with that, Madam Chair, I yield back the balance of my time.
I thank the gentleman. Do other members seek recognition for an opening statement? Start here. The chair recognizes Mr. Engel.
Yes, thank you. Dish cuts. Medicaid dish payments help hospitals and health systems serve some of our nation's most vulnerable communities, certainly in New York. In fiscal year 2017, Medicaid dish payments amounted to $18.1 billion, allowing safety net providers to deliver free or subsidized care to millions of Americans. Without congressional action, these vital payments would be cut by $4 billion in the upcoming fiscal year and $8 billion for the following year. That's just simply unsustainable, untenable. In May, 300 members of the House joined Congressman Pete Olson and me in urging a swift resolution to address these impending cuts, and I'm very pleased that the amendment before us will not only eliminate these cuts for fiscal years 2020 and 2021, but will also halve the cuts for fiscal year 2022. Over a 3-year period, this amendment will preserve $16 billion in Medicaid dish payments. This is a lifeline for safety net hospitals that serve my constituents, including Montefiore Health System, New York Presbyterian, St. Joseph's Medical Center, and St. John's Riverside. I also urge my colleagues on both sides of the aisle to support the legislation which will reauthorize funding for the National Quality Forum for 3 years. NQF is a multi-stakeholder panel that develops programs and tools to improve the quality of patient care in New York. 22 healthcare organizations have partnered with NQF to ensure patients are receiving high-quality care. In fact, the Greater New York Hospital Association and the Healthcare Association of New York State are working with NQF to implement an opioid stewardship program to address the ongoing drug epidemic. So I look forward to supporting the bills before us today, and I yield back the balance of my time.
The gentleman yields back. Dr. Bouchon is recognized for 3 minutes.
Chairwoman Eshoo, thank you for holding this important markup today and working in a bipartisan manner on these important bills before the subcommittee. Today, we will be considering H.R. 3630, the No Surprises Act, to address the problem of surprise medical billing. Patients should not be hit with high medical bills when receiving care at an in-network facility, only to find out later that a doctor who treated them was not in their network. I support the goal of the No Surprises Act, which seeks to hold innocent patients harmless in those situations. I do believe the bill as drafted would have some potential unintended consequences. The establishment of a benchmark set at the median in-network rate without an option for an independent dispute resolution process could create unintended consequences for patients and physicians. Specifically, I worry that without an independent dispute resolution process, physicians will be arbitrarily dropped from insurance plans and patients will lose access to the doctors they trust. In fact, narrow insurance networks and arbitrary contract cancellations with drastic cuts for providers has occurred in California since their benchmark law took effect. According to the California Medical Association, there will be a letter being submitted into the record that was sent to Chairman Alexander and Ranking Member Murray on the Senate side from the California Medical Association outlining this issue. Additionally, the bill references 2019 as the base year for future rates. I have learned that in the last few days, at least one major insurer has canceled its contract with providers and offered new contracts at a 30% lower payment rate. The insurer apparently told the providers that these cancellations are explicitly connected to the 2019 base in the bill for future payments. I believe we must prevent this sort of gaming of our well-intended efforts to protect patients. So Chairwoman Eshoo, Ranking Member Burgess, Chairman Pallone, and Ranking Member Walden, I ask that you continue to work with members of the committee to address these concerns before the full committee markup. I believe that establishing an independent dispute resolution process that protects patients and ensures a fair payment for the provider and honestly for the health plan is a part of the best solution. I yield back.
The gentleman yields back, and I heard what you said, and I'm here to work with everyone on it, because we have to have the surprise
Thank you.
billing legislation signed into law. The chair now recognizes the gentlewoman from California, Ms. Matsui, for her 3 minutes for an opening statement.
Thank you very much, Madam Chair. This committee is advancing critical legislation today, and I appreciate that much of the work has been done in a bipartisan basis. The markup of all the bills before us highlights the important efforts and investments this committee has made to bolster our nation's healthcare system. In particular, I'm encouraged that we are considering H.R. 728, which supports our nursing workforce. Nurses are truly on the front lines of patient care. Given the provider shortage and public health challenges currently facing our healthcare system, a thriving nursing workforce is more important than ever. The Title VIII Nursing Workforce Reauthorization Act recognizes the value of investing in the education and retention of our nation's nursing workforce. I'm also encouraged that the committee is acting to protect patients from costly surprise medical bills. These large, unexpected out-of-pocket costs can have devastating effects on working families, and patients should not be bearing the cost of the failure of insurers and providers to contract. However, I hope we can continue discussions on ways to ultimately resolve the issues related to provider payments and surprise billing. By doing so, it is my hope that we can get to the best solution to preserve patient access and lower health care costs. It is important we take the time to exercise due diligence of the various proposals and find ways to work together and with stakeholders in crafting a fair and effective solution to protect patients from surprise bills. Thank you, Madam Chair, and I yield back.
The gentlewoman yields back, and the chair recognizes the gentleman from Montana, Mr. Gianforte, for his 3 minutes for an opening statement.
Thank you, Chairwoman Eshoo. I'm pleased to see quick markup of so many important bipartisan bills, ensuring robust public health infrastructure, transparency in the pharmaceutical market, and no surprise billing are all vital to lowering costs in our healthcare system. I'm glad we're able to come to a bipartisan agreement to reauthorize our community health centers, National Health Service Corps, teaching health centers, and the Special Diabetes Program for Indians. All of these programs are incredibly important for the state of Montana. I fully support these programs and the work they do in our state. I'm a proud co-sponsor of the Autism Cares Act. I know funding for this program has been used to identify thousands of kids who otherwise may not have been diagnosed as on the spectrum in Montana. Finally, I'm glad we're bringing attention to the problem of surprise billing. Just last month, I heard from a woman in Ekalaka who had received a $70,000 surprise bill from a small Montana hospital. We need to ensure that all patients who are trying to work through our convoluted system in good faith are not victimized when providers and insurers cannot agree. At the same time, we need to ensure we're not harming rural providers in the process. I look forward to working with my colleagues to end the practice of surprise billing and to reauthorize these important programs. And with that, I yield back.
Thank you. The gentleman yields back. I believe that concludes our, okay. The chair recognizes the gentleman from Illinois, Mr. Rush, for 3 minutes.
I want to thank you, Madam Chair, and I want to thank Ranking Member Burgess, Chairman Pallone, and Ranking Member Walden for scheduling this important markup. I'm pleased that the subcommittee is making progress on so many important bills today. It is critical that we take action to reauthorize programs which dramatically improve and even save the lives of vulnerable populations, including newborns and children. We're also working to ensure sustained funding for our community health centers. The 8 federally funded health centers in my community, in my district, serve over 340,000 patients. Community health centers provide affordable and accessible health care to patients in Chicago and around the country who depend on this life-saving care. I'm also glad that the subcommittee is taking action today to prevent the schedule reduction for DISH programs from going into effect. These proposed cuts will be devastating to the hospitals in my district and will result in curtailing of life-saving services. I look forward to consideration of all 10 bills that are before us today, and I'm also, and as all are critical to the health of individuals across the nation. With that, Madam Chair, I yield back the balance of my time.
The gentleman yields back. Is there anyone from the Republican side that wishes to make an opening statement? Seeing no hands, are there any on the Democratic side that wish to make an opening statement? Well, I believe that concludes our opening statements. So pursuant to committee rules, members' written, open, brilliant opening statements shall be made part of the record. So be sure to submit them to the clerk's desk. At this time, we'll begin bill consideration. The chair calls up H.R. 2781, the Empower Act, the Empower for Health Act. The clerk will report the title of the bill.
H.R. 2781, a bill, excuse me, to amend Title VII of the Public Health Service Act to reauthorize certain programs relating to the health professionals.
Without objection, the first reading of the bill will be dispensed with, and the bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. I will now recognize Dr. Burgess to offer manager's amendment. What is your amendment labeled, Dr. Burgess?
Amendment 1.
The clerk will report the amendment.
Amendment to H.R. 2781 offered by Mr. Burgess of Texas, page 2, line 25.
Without objection, the reading of the amendment will be dispensed with, and Dr. Burgess is recognized for 5 minutes to speak in support of the amendment.
Thank you. The Educating Medical Professionals and Optimizing Workforce Efficiency and Readiness Act, or the Empower for Health Act, will reauthorize Title VII of the Health Professions Workforce Programs for fiscal years 2020 through 2024. The Title VII programs have expired but continue to receive appropriations. As the authorizing committee, is our obligation to reauthorize. Title VII of the Public Health Service Act includes various programs that are vital to building and maintaining a well-educated, well-trained physician workforce. Area health education centers are critical in providing both medical education and healthcare services to medically underserved areas. And the Primary Care Training and Enhancement Program provides grants to hospitals and health professional schools to develop and operate supplemental primary care programs. The bill reauthorizes loan repayment for child and adolescent psychiatry and mental and behavioral health. Such funding is important for addressing mental health and behavioral health of young Americans and will better equip our nation's healthcare workforce to address the mental health needs of children across the country. This amendment to H.R. 2781 makes some technical changes to the pediatric subspecialty language so that it will better align and address current workforce challenges. This amendment also makes some technical changes to the bill is introduced to account for technical assistance from the Health Resources and Service Administration at the Department of Health and Human Services. Reauthorizing Title VII programs is overdue. I strongly urge members to, on this subcommittee, to support this bill. I'm grateful for the chance to hear it today, and I will yield to any other member or yield back to the chair.
The gentleman yields back. I'd like to recognize myself to strike the last word and speak on the underlying bill for 5 minutes. This legislation, the Empower for Health Act of 2019, was introduced by Representatives Burgess and Schakowsky, and I want to thank them for their work. It reauthorizes Title VII Healthcare Workforce Development Grant Program for 5 years. And I think that those are the two operative words, 5 years. And that's very good news for this workforce across the country. According to the American Association of Medical Colleges, our country could see a shortage of up to 120,000 physicians by 2030. 120,000 physicians. There are so many communities that don't even have that population. This would have a devastating effect on patient care across our country, with rural and already underserved areas being hit the hardest. Title VII programs provide funding for medical schools to train the next generation of physicians. And the programs help to increase health workforce diversity by increasing the representation of minority and disadvantaged students in the health profession. These important programs include Centers of Excellence, Health Professions Training for Diversity Program, Primary Care Training and Enhancement Grants, Training in General Pediatric and Public Health Dentistry Grants, Area Health Education Centers, the National Center for Healthcare Workforce Analysis, and Public Health Workforce Grants. These programs support loan repayment and provider training experiences in primary care, in dentistry, in rural or underserved areas, and in community-based settings. HRSA estimates are that through all of its health profession training programs, over 400,000 participants were trained at 20,000 sites during the academic year of 2017-18. Nearly 9,000 of those participants were trained in a medically underserved community. So this is a program that is so worthy of the support of this entire committee and the entire Congress. Studies have found that students who attended schools with Title VII funding were significantly more likely to work in underserved communities and to practice primary care. And this is something that we can all not only support but be proud of. So this bill makes critical federal investment in our nation's physician workforce, and I urge all of my colleagues to support it. Now, are there other members that seek recognition to speak on the amendment? Seeing none, no further debate. We'll proceed to a vote on the amendment. All those in favor of the amendment will signify by saying aye.
Aye.
Aye. Those opposed? In the opinion of the chair, really close call, the ayes have it. The amendment is agreed to. Are there any further amendments to this legislation? Mr. Rush? The chair recognizes Mr. Rush to offer his amendment.
Madam Chair, I have an amendment at the desk.
What is your amendment labeled?
044, number 44.
The clerk will report the amendment.
Amendment to H.R. 2781 offered by Mr. Rush of Illinois. At the end of the bill, add the following new section.
Without objection, the reading of the amendment will be dispensed with, and the gentleman is recognized.
I want to thank you, Madam Chair. Madam Chair, there is an alarming level of underrepresentation within the health workforce. African Americans make up a small fraction, less than 5%, of physical therapists, occupational therapists, speech language pathologists, and audiologists. I'm proud to work to fix this problem in a bipartisan manner, along with my friend, Representative Kathleen McMorris Rogers. The amendment I am offering today authorizes funding for college and university programs in the specified medical fields. This funding will be used to attract, recruit, and retain students who are racial or ethnic minorities or who are from disadvantaged backgrounds. My amendment would encourage individuals from these underrepresented groups to enter into and complete these specified programs. It has been proven, Madam Chair, that patients have better health outcomes when their doctor is of the same racial or ethnic background. It is only by having a medical workforce that reflects the diversity of our nation that we can provide the best health care possible. Furthermore, when minorities and those from underserved communities pursue a career in the medical field, they are far more likely to work in underserved and rural areas. This will help address the shortage of health professionals in these communities. No community, Madam Chair, should be without access to the care they need. Finally, we know funding like this works. This amendment is modeled after the highly effective Title VIII Nursing Workforce Development Program, which increased the percentage of racial and ethnic minorities pursuing careers in nursing. I urge, Madam Chair, my colleagues to support this amendment, which provides a simple but powerful fix for a historic and problematic problem that is the underrepresentation in the fields of physical therapy, occupational therapy, speech and language pathology, and audiology. Thank you, Madam Chair, and I yield back the balance of my time.
The gentleman yields back, and we thank him for his continuing work to really have a workforce in our country that reflects the makeup of our country, how important it is. Are there other members seeking recognition to speak on the gentleman's amendment? The gentlewoman from Delaware, the Honorable Lisa Blunt Rochester, is recognized for 3 minutes.
Thank you, Madam Chair. And I want to thank my colleague, Mr. Rush, for introducing the Allied Health Workforce Diversity Act, and I am a proud co-sponsor of this critical bill. Speech-language pathology, occupational therapy, audiology, and physical therapy are all integral to helping Delawareans and Americans live healthy and independent lives. And as Mr. Rush shared, according to the Health Resources and Services Administration, less than 5% of health professionals in these fields are African American. That number is staggering. And as he also shared, the opportunity to provide these kind of services for minority and disadvantaged folks from different backgrounds will really be something that will make for a better health outcomes. This amendment is an opportunity to support underrepresented communities and encourage more diversity in the medical field. A more diverse workforce allows us to better address the health needs of all Americans by leveraging a broader array of knowledge, experience, and cultural understanding. I urge my colleagues to join me in supporting this amendment, and I yield back my time.
The gentlewoman yields back. Is there anyone on the Republican side that would like to speak on the amendment? Seeing there's no further debate, we'll proceed to a vote on the amendment. All those in favor of the amendment will signify by saying aye.
Aye.
Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. The amendment is agreed to. Are there further amendments to this legislation? Seeing none, the question now occurs on favorably forwarding H.R. 2781 as amended to the full committee. All those in favor of forwarding H.R. 2781 as amended to the full committee will signify by saying aye. Aye. Those opposed? In the opinion of the chair, the ayes have it. 2781, as amended, is forwarded to the full committee. The chair calls up H.R. 728, the title 8, Nursing Workforce Reauthorization Act of 2019, and the clerk will report the title of the bill.
H.R. 728, a bill to amend Title 8 of the Public Health Service Act to extend advanced
Without objection,
education
the
nurse-
first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any time. I will now recognize Ms. Matsui of California to offer a manager's amendment.
Thank you, Madam Chair. This is amendment number 1, I believe.
Clerk will report the amendment.
Amendment to H.R. 728 offered by Ms. Matsui.
Without objection, the reading of the amendment will be dispensed with, and Ms. Matsui is now recognized for 5 minutes to speak in support of her amendment.
Thank you very much, Madam Chair. As the baby boomer population ages and as a younger generation of growing families, it is vital that our country has a well-trained nursing workforce to keep up with the demand for quality health care. This amendment and the underlying bill help bolster our nursing workforce and improve access to critical care. The amendment I'm offering today ensures that we invest fully in our nursing workforce by raising the authorization levels in the underlying bill to reflect the amount the House agreed to in its appropriations bill earlier this year. The amendment also makes a simple change that will ensure that all nurses practicing in critical shortage facilities have the opportunity to benefit from the loan repayment programs authorized in the legislation. For over 50 years, the Title VIII nursing workforce development programs have been the largest dedicated source of funding to improve the nursing workforce demand. The programs support advanced nursing education, diverse nursing workforce quality and retention, and initiatives to help train the next generation of nursing faculty. Nurses are the largest sector of the healthcare workforce, with more than 4 million practicing nurses treating and educating patients across their entire lifespan. A robust nursing workforce is essential to meeting current and future healthcare demands in all areas, especially rural and underserved communities. Looking ahead, the Bureau of Labor Statistics projects that demand for registered nurses is scheduled to increase by 15% by 2026, and advanced practice registered nurse demand is scheduled to grow by 31%. In my own state of California, we recently recovered from a nursing shortage, which is an example of why reauthorizing the Title VIII nursing workforce program is integral to preventing another one. I thank my colleague, Representative David Joyce, for working with me on the Title VIII Nursing Workforce Reauthorization Act. It is vital that we continue to invest in training, development, and retaining a strong, diverse, competent nursing workforce across all care settings. This amendment and the underlying bill will go a long way to making that possible. I ask all of my colleagues to support it, and I yield back the balance of my time.
Gentlewoman yields back, and I will recognize myself to strike the last word and speak on the underlying bill for 5 minutes or less. The Title VIII Nursing Workforce Reauthorization Act was introduced by Representatives Matsui, Joyce of Ohio, McKinley of West Virginia, Castor of Florida, Davis of Illinois, Gabbard of Hawaii, Bonamici of Oregon, and Underwood of Illinois. So I salute all of the members that have worked so hard on this bill. It does reauthorize federal nursing workforce development grant program for 5 years, which I think, again, the two operative words are 5 years. This is a healthy extension, and I think the program is worthy of it because it funds the grants and scholarships for graduate and undergraduate nursing education in specified areas of nursing, including cultural competency, workforce diversity, nurse faculty members, advanced education nurses, and geriatric nursing. So it's not just the nurses that appear at our bedside if we happen to be in the hospital. This really goes across all nursing in our country. And the programs support recruitment, retention, advanced education of skilled nursing professionals to address the shortages that exist in our country. Over 25,000 nurses were supported by Title VIII programs during the 2017-18 academic year. That's a lot of nurses, 25,000. That includes over 6,500 students who were supported through the Nursing Workforce Diversity Program. And today's existing nursing workforce will not be adequate to meet the complexity of healthcare needs in our country unless there's an increased investment. One goes with the other. And that investment is made to train skilled nurses. So at a time when our healthcare workforce is diminishing, the federal government really should use every tool to recruit and train healthcare professionals to meet the needs of all Americans. And I think that's exactly what this bill does. It deserves the vote of not only the subcommittee, the full committee, but the full Congress. With that, I will, what will I do? I will yield back. And are there any other members that wish to speak on the amendment? From either side. Seeing none, if there's no further debate, we'll proceed to a vote on the amendment. All those in favor of the amendment will signify by saying aye. Aye. All those opposed signify by saying no. In the opinion of the chair, the ayes have it. The amendment is agreed to. Are there any further amendments to this legislation? Seeing none, the question now occurs on favorably forwarding H.R. 728 as amended to the full committee. All those in favor of forwarding H.R. 728 as amended to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. H.R. 728 as amended is forwarded to the full committee. The chair calls up H.R. 1058, the Autism Cares Act of 2019. The clerk will report the title of the bill.
H.R. 1058, a bill to reauthorize certain provisions of the Public Health Service Act relating to autism and for other purposes.
Without objection, the first reading of the bill will be dispensed with, and the bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. I now recognize myself to offer a manager's amendment. The amendment is labeled 41058 SC Amendment 01. The clerk will report the amendment.
Amendment to H.R. 1058 offered by Ms. Eshoo. Page 10, beginning on line 15, strike.
Without objection, the reading of the amendment will be dispensed with. I will now recognize myself for 5 minutes to speak in support of the amendment. My colleagues, this amendment simply increases the authorization of appropriations to $296 million for programs run by the National Institutes of Health. Since the Autism Cares Act was introduced by my friends, Representatives Doyle and Chris Smith, the House has passed an appropriation bill that increases funding for the programs authorized in their legislation. This manager's amendment updates the authorization levels to match the increased investment the House has made in autism care programs. During our hearing, we heard how critical the Autism Cares programs are. Researchers, physicians, parents, and patients rely on it to fund the support services, the research, the training, and the surveillance programs to get people the diagnosis and services they need. The Act expands efforts to conduct what I just described. Black and Latino children with autism tend to be diagnosed later than white children and are often misdiagnosed, which is really a disaster for the individuals when they are misdiagnosed. They have less access to services and they're underrepresented in most autism research. So this 5-year reauthorization addresses these disparities as well as other challenges relative to autism research, education, detection. And the CARES Act funds this research at the NIH to understand the biology behind autism. It helps to build infrastructure at CDC to advance our understanding of autism and to train medical providers on screening, diagnosis, and intervention. In my congressional district, I'm very proud that Stanford University receives CARES funding to do this very important research. It's an area that's been left behind in the country, still misunderstood, and we still have ways to go. So while there's still so much that's unknown about autism, this legislation renews the federal government's commitment to getting those answers. So with that, I will, if there are there other members that wish to speak on this amendment?
Would you yield to
On
me?
the act. I'd be glad to recognize Dr. Burgess.
I just want to add my support for the underlying bill and recognize the long work that Representative Smith and Doyle have put into this product, and that Mr. Smith was kind enough to attend our subcommittee hearing on this, and it is important work, and it deserves reauthorization. I'll yield back.
I thank Dr. Burgess, and I did recognize Representative Smith when he was here, even though the committee rules are not so supportive of that. But the two have been great partners and founded the Autism Caucus. And now I would like to recognize the gentlewoman from Michigan, Ms. Dingle, for her 5 minutes.
Thank you, Madam Chair. I move to strike the last word and speak in favor of the legislation. Madam Chair, I'm proud to co-sponsor the Autism CARES Act, and I urge my colleagues to support this important bill. Among its many important provisions, the Autism CARES Act provides funding for LEND programs, L-E-N-D, which help train relevant professionals and improve our response to autism. In Michigan, our LEND program is a collaboration of 6 different universities, 3 of which are located in my district: Wayne State, the University of Michigan at Dearborn, and the University of Michigan in Ann Arbor. Our district is extremely proud of these institutions and the work they're doing to address autism and train the next generation of professionals. And none of this would be possible without the Autism CARES Act. In addition to LEND, the Autism CARES Act will reauthorize essential research that improves our understanding of autism and will expand access to earlier interventions. This bill also coordinates the federal government's efforts to address autism and provides important support for children and adults with autism and their families. I, like all of you, thank Representative Doyle and Smith for their relentless leadership on this issue, and I look forward to this passing out today and getting to full committee, and I really hope we're able to pass it in the House of Representatives before it expires at the end of September. I urge my colleagues to vote for this, and thank you, Madam Chair, for your leadership.
Thank you. Are there other members seeking recognition to speak on this from either side? If there's no further debate, we'll proceed to a vote on the amendment. All those in favor of the amendment will signify by saying aye. 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 All those opposed signify by saying no. In the opinion of the chair, the ayes have it. The amendment is agreed to. Are there further amendments to this legislation? The question now, seeing none, the question now occurs on favorably forwarding H.R. 1058 as amended to the full committee. All those in favor signify by saying aye. 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 Those opposed signify by saying no. In the opinion of the chair, the ayes have it. H.R. 1058 as amended is forwarded to the full committee. The chair now calls up H.R. 2507, the Newborn Screening Saves Lives Reauthorization Act of 2019, and the clerk will report the title of the bill.
H.R. 2507, A bill to amend the Public Health Service Act to reauthorize certain programs under Part A of Title 11.
Without
of such
objection, the
act.
first reading of the bill will be disposed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. The chair will now recognize Ms. Kelly to offer a manager's amendment and is recognized for her 5 minutes. No. Oh, the clerk has to, what is your amendment labeled? I'm sorry.
Newborn Screening Saves Lives Act.
Without objection, the reading of the amendment will, I'm sorry. Before I get rid of it, the clerk will report the amendment.
Yes, ma'am. Amendment to H.R. 2507 offered by Ms. Kelly. Amend Section 2 to read as follows.
Without objection, the reading of the amendment will be dispensed with, and I will now recognize Ms. Kelly for her 5 minutes to speak in support of the amendment.
Thank you, Madam Chair. Every year, over 12,000 babies are born with health conditions that require early detection and immediate treatment. Since the first newborn screening test was developed in the early 1960s, science has achieved great advances. For example, let's consider cystic fibrosis. What once was a death sentence and an untreatable condition is now treatable by several medications, and we're seeing progress toward a cure. To this day, however, infants diagnosed with the disease and the families who love them rely on early screening so that the baby may receive timely treatment. In the 11 years since the Newborn Screening Saves Lives Act was first signed into law, we have made tremendous progress toward the goal that every baby born in the U.S. receive recommended screening for treatable conditions that can benefit from early detection. In 2008, only 15 states screened newborns for the 29 recommended health conditions. Today, every state screens newborns for those 29 recommended conditions, and as more conditions are added to the Recommended Uniform Screening Panel, or RUSP, many states are keeping up and expanding what screening tests they offer to newborns, but some states still need more help, and as medical research improves, we've got to make sure that states have the resources they need to expand capacity, ensuring that every child receives recommended screening. This amendment to the Newborn Screening Saves Lives Act makes process improvements which will help ensure that infants receive the follow-up care they need, allows for states to use grant funds to expand testing capacity and infrastructure, and also helps bring states into the modern age of medical advancement by asking the Advisory Committee on Heritable Disorders in Newborns and Children to provide recommendations on the use of safe and effective genetic testing by healthcare professionals. Moreover, this amendment will make it easier for states to adopt recommended screening protocols and will help ensure that we modernize the screening process for the next generation. I thank Congresswoman Royale Allard for all of her tremendous work over these numerous years on the Newborn Screening Saves Lives Act. It is literally saving lives. Finally, I urge all my colleagues to support this amendment. I yield back.
The gentlewoman yields back. Is there, pardon me? Yes, I was just going to recognize him. The chair recognizes Mr. Hudson for his 5 minutes.
Thank you, Madam Chair. First, I'd like to thank Representative Kelly for her leadership and for working with me on this amendment. I know we both agree that our children are our most valuable treasure, and it is our best interest to do everything we can to help and protect them. This amendment will go a long way to improving the benefits of newborn screening panels around the country and helping children born with serious medical conditions. Newborn screenings help parents catch medical conditions sooner, allowing better planning for medical care and, in some cases, better medical outcomes. By adopting this amendment, we'll provide better resources to implement the recommended uniform screening panel, encourage broader use of genetic testing, which can help catch diseases such as Duchenne muscular dystrophy, and allow grants to be used to follow up with patients who have stopped seeing providers. Finally, this amendment will expand the National Academies of Medicine report to evaluate how delays in adopting new screening panels can impact patients. I encourage my colleagues to support this critical amendment, and I thank you again, Representative Kelly, for working with me, and Madam Chair, I yield back.
The gentleman yields back. Are there any members on the Democratic side that would like to speak to the legislation? I'll recognize myself to strike the last word and speak on the underlying bill. I want to applaud the members that have worked so hard on this and for a long time. Certainly Representative Kelly, Mr. Hudson, Lucille Roybal Allard, Mr. Simpson from Idaho, Ms. Clark from Massachusetts, and Ms. Herrera Butler from Washington State. Again, this is a reauthorization for 5 years. It's very important to have a long runway on these programs. This is going to give parents peace of mind that their newborn will receive comprehensive diagnostic screening no matter where they live in the country. These are our newest citizens, and so detection is so essential to address early on. And that's what's going to give the parents the peace of mind. And then we can see that, that these little angels will be able to grow up in a country and know that the country loved them. And they may not know it, but we will know that we will have done the right thing. Through these screenings, each year, over 12,000 babies live healthier and longer lives as a result of it. So I can't think of, I think that this is exciting. It is a reauthorization, but I think that it's worth taking a few moments to drill down and say bravo, because there are tremendous savings involved in this as well. Treating an infant with SCID can cost Medicaid as much as $2 million. But when the newborn is diagnosed not so soon after they're born, they can be cured with a bone marrow transplant costing about $100,000. So this is good work, and this is good news for those that are being born in our country. And is there any other member that would like to speak to the legislation? Seeing none, no further debate. We'll proceed to a vote on the amendment. All those in favor of the amendment will signify by saying aye. Aye. All those opposed will signify by saying nay. In the opinion of the chair, the ayes have it. The amendment is agreed to. Are there any further amendments to the legislation? The question now occurs on favorably forwarding H.R. 2507 as amended to the full committee. All those in favor of forwarding H.R. 2507 as amended to the full committee will signify by saying aye. 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 All those opposed will signify by saying no. Hearing none, in the opinion of the chair, the ayes have it. H.R. 2507, as amended, is forwarded to the full committee. Amen. That's really terrific, I think. The chair calls up H.R. 776, the Emergency Medical Services for Children Program Reauthorization Act of 2019. The clerk will report the title of the bill.
H.R. 776, a bill to amend the Public Health Service Act to reauthorize the emergency medical services for children.
Without objection, the first reading of the bill will be dispensed with, and the bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any time. Are there any members who seek recognition to offer an amendment? All right. The question now occurs. What? Well, I'll just say I'll recognize myself just for a minute to strike the last word and speak on the underlying bill. This reauthorization, and I want to make a point of reading out the names of members that have worked on it because they deserve credit. Representatives King from New York, Representative Castor of Florida, Representative Stewart of Utah, and Mr. Butterfield of North Carolina. We applaud your good work. excellent work. It reauthorizes emergency medical services for children, this program, for 5 years. This is another 5-year reauthorization, and I think that that is very important. I don't think there's anything scarier than when a child is critically ill or injured. Parents know this. If it, thank God, hasn't happened in your family, it crosses every parent's mind that it could happen. So parents should be able to trust that their child is going to receive the kind of medical care that they need, no matter what hospital they go to. So this bill reauthorizes the only federal program dedicated to improving emergency medical services for children. And children are not just little adults. They require specific types of equipment, they require special dosing, and they require special medication. And that's why this reauthorization is so important. We have to make sure that the littlest and most vulnerable Americans are taken care of during emergencies. So I think everyone is going to vote for this and be glad that they did. And with that, the question now occurs on favorably forwarding H.R. 776 to the full committee. All those in favor of forwarding H.R. 776 to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. H.R. 776 is now forwarded to the full committee. The chair now calls up H.R. 2035, the Lifespan Respite Care Authorization Act of 2019, and the clerk will report the title of the bill.
H.R. 2035, a bill to amend Title 29 of the Public Health Service Act to reauthorize the program under such title related to lifespan
Without objection, the
respite
first
care.
reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and is open for amendment at any point. I will now, am I recognizing myself? We have an amendment. I will now recognize myself to offer a manager's amendment, and the amendment is labeled H2035 SCD AI, I think it says AINS 01. Clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 2035 offered by Ms. Eshoo. Strike all
Without
after the
objection, the
enacted.
reading of the amendment will be dispensed with, and I'll recognize myself for 5 minutes to speak in support of the amendment. Colleagues, this manager's amendment makes technical changes to Representatives Langevin and McMorris-Rogers Bipartisan Lifespan Respite Care Reauthorization Act. This is an important bill because it reauthorizes this program. Again, I want to emphasize 5-year reauthorization, which I think I'm really fond of 5 years, and it increases funding for the program. So that's a great set of bookends on the legislation. The program has provided grants to 37 states and Washington, D.C. since it was created in 2009. More than 40 million Americans serve as family caregivers. This program is their lifeline. Anyone that's been a caregiver here on the committee, I think there are women that are going to raise their hands. I don't know if the sons or son-in-laws. Wonderful, Dr. Burgess. I know I have, certainly Ms. Dingle has. We know what this means. Being the unpaid caregiver for a loved one can be physically and emotionally exhausting and isolating. The average family caregiver is a woman who works full-time and is providing care to both aging parents, a spouse, a loved one, and or children living at home. So through this 5-year reauthorization, the bill allows caregivers to take a temporary break from their, I think, back-breaking caregiving responsibilities. About 85% of family caregivers of adults don't receive any respite services whatsoever. And that's why this bill increases funding for this valuable program by $10 million each year. Through the program, caregivers can receive support services from highly qualified, well-trained staff. A caregiver is not going to seek out respite unless they have the peace of mind that a professional person is going to step in and help take care of the loved one. So these programs are so important to so many Americans, mostly women, as I said, who are taking care of their loved ones every day. I'm very proud that the subcommittee is advancing this reauthorization and deserves the unanimous support of the entire committee. Now, are there any other members that would like to speak on the amendment? The chair recognizes the gentlewoman from Michigan, Ms. Dingell, who knows a thing or two about respite care.
Thank you, Madam Chair. I move to strike the last word and speak in favor of the legislation.
So moved.
Madam Chair, I think you were eloquent in your describing of this bill. This bill is very, very, very important to me, and I'm proud to be a co-sponsor. As you know, it's very personal. I was a primary caregiver to John, and I experienced firsthand I'm luckier, and I say this every day of the week, I am luckier than 99 9/10 of the people in this country. And I can't tell you the number of days I wanted to take my head and put it against a wall because we have a very fragmented, broken long-term care system. Yeah. And there are millions of people with far fewer resources than people like us who struggle even more to access long-term care. The Lifespan Respite Care Act provides essential community-based respite care services for family caregivers of children and adults. You can't imagine how important it is for caregivers to have just a little support when you're taking care of a loved one. You know, this may be sad, but for me, you guys were my respite. And you gave me, I know, think about that. But our nation's 43 million family caregivers provide $470 billion in unpaid care. And providing respite care to improve the caregiver's physical and mental health is just the least that we can do. So, as the chairwoman said, this reauthorizes it for 5 additional years, and it increases the funding, which is really important. I want to thank Representatives Langevin and McMorris-Rogers for their leadership, which has been unstinting and great, and I urge everyone here to support this important legislation. We have 10,000 people turning 65 every single day. We have a crisis coming. I yield back the balance of my time.
The gentlewoman yields back. If there's no further discussion or amendments, we will proceed to a vote on the amendment in the nature of a substitute. All those in favor of the amendment in the nature of a substitute to H.R. 2035 will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. The amendment in the nature of a substitute to H.R. 2035 is agreed to. The question now occurs on favorably forwarding H.R. 2035 as amended to the full committee. All those in favor of forwarding H.R. 2035 as amended to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. Anyone says no, we're going to have Dingell and Eshoo on your back, but that's not going to, you're going to be relieved of that. In the opinion of the chair, the ayes have it. 2035 as amended is forwarded to the full committee. The chair now calls up H.R. 2296, the Fair Drug Pricing Act of 2019. The clerk will report the title.
H.R. 2296, a bill to require reporting regarding certain drug price increases and for other purposes.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. I will now recognize Mr. Carter to offer an amendment in the nature of a substitute. No?
Madam Chair, I have an amendment at the desk.
And what is your amendment labeled?
The amendment is labeled Ames 01.
The clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 2296 offered by Mr. Carter of Georgia.
Without
Strike all.
objection, the reading of the amendment will be dispensed with, and Mr. Carter is now recognized for 5 minutes.
Thank you, Madam Chair. Madam Chair, I have an amendment in the nature of a substitute. Madam Chair, during the first hearing we had on drug pricing this year, I mentioned how hopeful I was that drug pricing could be a nonpartisan issue. I mentioned how I thought this committee was always at its best when we were working together on big issues, whether it be cures, opioids, or anything in between. Today, I am so thankful that our drug pricing efforts continue to reflect the spirit of bipartisan collaboration. In all my years as a pharmacist, I've never had to ask if a patient was a Republican or a Democrat because it doesn't matter who you vote for. We're all paying for increasingly expensive drugs at the pharmacy counter. With this amendment, we will lower drug costs for patients by bringing a much-needed increase in transparency throughout our drug supply chain. From drug manufacturers, we'll have more and better reporting of what goes into drug pricing decisions. From PBMs, we'll get more transparency into their roles as middlemen and examine the marketplace for any anti-competitive behaviors. Our drug supply chain is incredibly complex, and we've all sat through multiple hearings of different stakeholder groups pointing the fingers at each other without much of an ability to open the hood and see how things are working for ourselves. But no longer will we have to settle for those he said, she said blame games. Sunlight is the best disinfectant, and I'm confident that the policies in this bill will help lower costs for patients. Is everything in the package the way I would have written it by myself? Of course not. The policies in this amendment are the products of multiple hearings where we heard support and concern from a variety of stakeholders. The policies in this amendment are the products of lengthy, hard-fought negotiations between members and staff from both sides of the aisle. I believe the bill is better off for that process. Chairman Pallone and Chairwoman Askew, I want to thank you for your leadership throughout this process. You let us hear from stakeholders who had concerns, and you worked with us to make sure this is a strong product that can receive bipartisan support. Finally, I also want to thank the staff on both sides of the aisle for all their hard work to get this amendment ready to vote on today. Madam Chair, today marks another strong step in this committee's work to lower drug prices for Americans. I encourage all of my colleagues to support this amendment and support this bill. I look forward to continuing to work with you all to get this good legislation across the President's desk so we can start delivering for patients across the country. Thank you, and I yield back the remainder of my time.
I thank the gentleman. The gentleman yields back. I now would like to recognize the gentleman from Maryland, Mr. Sarbanes, to speak on his amendment.
Thank you, Madam Chair. Well, I speak in support of this amendment that Representative Carter just spoke in support of the amendment in the nature of a substitute. And I want to thank him for his co-sponsorship, and I want to thank the committee for the strong bipartisan work on this bill and on the various bills that have been combined together in this amendment in the nature of a substitute. As you've heard, and as the committee obviously is proud of, this is a set of proposals that will allow consumers to access greater information about drug price increases, drug discounts negotiated by pharmacy benefit managers, drug pricing information under Medicare, and other critical data that helps to inform the prices we pay for prescription drugs. It incorporates provisions from several pieces of legislation, including Representative Schakowsky's Fair Drug Pricing Act, but also legislation that's been introduced that would promote transparency by our colleagues, Congresswoman Spanberger, Congressman Boyle, Nadler, Congresswoman Chu, Congressman Doggett, many others who've made transparency a #1 priority. It will hold drug manufacturers accountable for price increases above 10% in a year or 25% in 3 consecutive years by requiring the reporting and public disclosure of information pertaining to that drug. It also will address total expenditures for manufacturing, research and development costs and marketing and advertising, as well as information on the total revenue and net profit generated from the qualifying drug. Having this information when drug manufacturers raise their prices allows the public to have better insight into the motivations of drug manufacturers, and then the public can determine, we can determine, the true motivation of drug manufacturers when increasing prices. The amendment in the nature of substitute also ensures that manufacturers will face stiff civil monetary penalties should they fail to provide this information or should they knowingly provide false information as well. Additionally, I'm pleased that the amendment includes a provision to publicly disclose certain aggregated drug discounts obtained by pharmacy benefit managers when they negotiate rebates, discounts, and other price concessions. This is all really important information that the public has a right to know. As we learned from the hearings that we've conducted, particularly the drug supply chain hearing, oftentimes the pharmaceutical supply chain can be very opaque and confusing, and I believe strongly that this amendment shines a light on this system in a way that will allow consumers to have better understanding of drug prices and greater access to information. If we can get this legislation all the way through, and if these items become law, it really will represent a new day. And having this kind of transparency, information at our fingertips going forward, I think can be very instructive. It can help us build a stronger toolkit in terms of dealing with drug pricing overall. So for all those reasons, I want to thank my colleagues for introducing these measures. I strongly support this amendment in the nature of substitute, and I yield back my time.
The gentleman yields back. Is there, the chair recognizes Dr. Burgess for 5 minutes to speak on the substitute.
Thank you, Madam Chair. I just want to remark on that I appreciate the process conducted by the committee in getting the bill to this point. There is a need for more transparency in our healthcare system, and this legislation contains good transparency that I think can be supported. Members on both sides of the dais, including myself, requested some changes to the bill as considered from our legislative hearing to prevent some potential unintended consequences for patients. I appreciate the committee's willingness to engage in discussion and amend the legislation for these concerns, including those Dr. Bouchon and myself had with the provision regarding samples of medications. So I do support the legislation, and I encourage other members to do so as well. I yield back.
The gentleman yields back. Is there anyone on the Democratic side? The chair recognizes the chairman of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Madam Chair. I move to strike the last word and speak in favor of the amendment in the nature of a substitute offered by Mr. Carter and Mr. Sarbanes. This amendment represents a strong bipartisan compromise that will allow consumers to have greater access to information about the rising costs of drugs. Most notably, this AINS requires robust reporting for drug manufacturers when they choose to raise the price of a drug more than 10% in 1 year or 25% in 3 consecutive years. Prior to a price increase, drug manufacturers are required to disclose to the Secretary of the Department of Health and Human Services critically pertinent information such as manufacturing expenditures, total revenue and profits, and marketing expenses for the drug. The Secretary is then required to make publicly available this information on the website for the Department of Health and Human Services so consumers can see for themselves the real reasons drug prices are going up, as well as compare expenditures, profits, and other costs to determine whether the manufacturer can justify the rationale for the price increase or if the increase instead gouges consumers for no other reason than just additional profit. And I'd also like to highlight that this amendment includes 2 strong civil monetary penalties. One penalty is for noncompliance, that is to be levied each day that a manufacturer fails to submit the information required. And there's also an additional penalty should a manufacturer submit knowingly false information to the Secretary as well. I believe strongly, it talked about consumers in our opening statement, that consumers have a right to know this information. I believe no matter what it is in this committee, if you give consumers the right to know, it makes a difference. Americans should be able to understand why their life-saving drugs are increasing in price year after year. So this amendment not only requires greater disclosure for drug manufacturers when they raise their prices, it also requires greater disclosure of certain aggregated rebates, as well as other fees negotiated by pharmacy benefit managers. It would also require greater reporting of average sales price, ASP data, from drug manufacturers in the Part B program. This enhanced reporting and oversight will result in real savings for the Medicare program, according to the Congressional Budget Office. So I want to thank Representative Schakowsky for her leadership on the underlying bill, as well as my Republican colleagues and Ranking Member Walden. I'm proud of the bipartisan agreement that we reached on this package of bills included in this amendment, and I believe it will bring greater transparency to the marketplace and to the fingertips of consumers who are the ones facing increasing costs each day. Again, consumers are what this committee is all about, trying to help consumers. So I urge my colleagues to support the amendment. Thank you, Madam Chair. Yield back.
Gentleman yields back. Chair recognizes the gentleman from Oregon, the ranking member of the full committee.
Thank you, Madam Chair. And I want to thank you, Chairwoman Eshoo, and sincerely thank you and Mr. Pallone for the commendable process. This is our committee at its best. The package of bills covered under the amendment in the nature of substitute were all worked on in good faith and with strong collaboration. We appreciate that. I think you really exercised our committee's jurisdiction, too, and I thank you for that by discussing these bills in an open hearing. What a concept. Willing to hear from all sides. And while some were marked up by other committees, we're the committee of primary jurisdiction, so I'm thankful the Energy and Commerce Committee is having our own unique and appropriate process. And you listened to the concerns that our members had as well. We appreciate that. Bottom line, drug pricing remains of great concern to all Americans, and it's the #1 issue at the 35 town halls I've held across my district so far this year. We know that prices seem to continue to rise, and while there are numerous reasons, patients rely on these medications, and we need to make sure they have access to them. This committee has worked to address this challenge, but there's more work to do, and this subcommittee has built off a foundation that I believe we laid last Congress in this committee, which has made a difference. Today, the package of bills is focused around transparency, and the healthcare market can benefit from more transparency to empower consumers and ultimately open up more choices and competition. First, the bill would require drug manufacturers to increase their prices over a certain threshold to justify their reasoning for doing so. While price increases can happen for a lot of reasons, from failed clinical trials to research and development to research that doesn't pan out, with the federal government being such a major purchaser of drugs, having the information on cost drivers is important for context. Next, the bill would ensure that manufacturers are reporting their average sales price to the Medicare program. I think this is really important because when they don't, the program pays more, and that's just not right. We know savings will be realized from this policy. Now, I still think there are some improvements we can make to the language to guarantee our full intent is realized, and I look forward to continuing those discussions as well, Madam Chair. We also follow a recommendation by MedPAC allowing information currently being collected on samples provided to patients to be analyzed by certain parties. I had some concerns when we started about this process about decreasing the ability of physicians to provide patients with samples of drugs to help those who cannot afford their medication, but I believe the risk of that outcome now is much lower because of our collaborative work. On Schedule II drugs such as hydrocodone or OxyContin, we ban the provision unless it is used for the treatment of addiction. This is already industry practice and just makes logical sense. We ask for more transparency in the rebates PBMs receive, while ensuring the data cannot be gamed to drive up costs. We also ask for a report delivered to the committee on PBM mergers, which is similar to a letter I sent last year to the Federal Trade Commission. And finally, we encourage the use of real-time benefits tools. This would allow the transparency many patients and providers want, allowing doctors to know which medications they can prescribe for the beneficiary at the lowest cost. As we work to shine a light on how drugs come to market and how they're priced, we need to realize the level of innovation we're seeing is unprecedented. And I believe any policies pursued by this committee must put the patient front and center, increase transparency, and protect the ability to develop cures for the next generation. So in closing, I want to end where I began, and that is I hope we remain committed to this bipartisanship, to American innovation, because if we get it right, we can deliver on our promise to the American people so that patients benefit. The process to get us to this amendment in nature of a substitute meets that test. And as often the case in negotiation, compromises were made, but I believe we've struck the right balance in this package to proceed. So I want to thank the staff, particularly Jacqueline Boland and Sam Satchel with Mr. Pallone's staff for working diligently with our committee staff to get us here today. We appreciate your good work, and I'm encouraged by our work on this bill, and I strongly support the amendment. And I thank Chairwoman and the Chairman of the full committee for this process and urge our members to support the amendment in the nature of a substitute. I yield back.
Thank the gentleman. He yields back. I want to recognize myself to strike the last word and speak on the amendment in the nature of a substitute. Last evening, which there are many evenings here during the week that I conduct telephone town hall meetings with my constituents, and last night was no different. We started about 10 o'clock Eastern time, but it's 7 o'clock at home. Thousands of constituents participate in it. Number one, it's convenient, and they get to ask me whatever they want, and you need to give them a direct answer. The very first question of a constituent last night was, what is the Congress doing on lowering drug prices? And I think that's a question that is presented to each one of them. They were gladdened when I told them, described to them what we were taking up today and what we have done so far in this Congress. So this legislation, all of the members that have worked on this, with this amendment, the bill also includes provisions proposed by Mr. Doggett and Buchanan, and it requires manufacturers to report the average sales price, the ASP, of Medicare Part B, B as in boy, drugs. This essentially, the bill will make sure that Medicare is paying the right price for Medicare Part B drugs. And everyone wants the right price for drugs. So that's in the amendment. It also includes provisions that require PBMs to report the discounts they negotiate with drug manufacturers. When we had our drug chain hearing, members on both sides of the aisle really drilled down on, so there is a negotiation and there are savings. Who accrues the savings? So this will require the PBMs to report the discounts they negotiate with drug manufacturers, and it's going to help to ensure that the discount is passed down through the chain to patients, which I think is a top priority of members from both sides. So, and at the hearings, we learned that there were 3 PBMs that control the majority of the market, and those PBMs own large pharmacy chains and specialty pharmacies, which I think is a potential conflict of interest. So with this bill, the FTC is going to scrutinize the PBMs to ensure that there aren't any distortions of the market. So I obviously support the bill. I think it's good legislation. The amendment enhances the legislation, and I yield back. Are there any other members that would like to be recognized? Let's see, go to this side. Republican side? Seeing none, the chair recognizes the gentleman that has been on this, and it's why he lost his hair, Mr. Welch. That's how hard he's worked. That's what you have to remember.
Reserving the right to object.
Yeah. We'll have to get some legislation going on hair growth. But with that, out of all due respect to Mr. Welch, you're recognized on a subject that he's worked very hard on for a long time.
Madam Chair, thank you for that really wonderful introduction.
I want to join in supporting my colleague. He's just reached perfection.
This is good, and it's building on the work that this committee has been doing against pay for delay, the Fast Generics Act. Transparency is good for consumers, bad for pharma. Secrecy is good for pharma and bad for consumers. So this is a tool that is going to be helpful. But I do want to just keep the pressure on us in this committee that we've got to get to a place where we concretely bring down the price of drugs. And we have waiting for us at some point a decision to make about whether there's going to be price negotiation for all drugs, not just in the VA, whether there's going to be international reference pricing, something that President Trump has talked about, and could be an effective tool to bring down prices so that our consumers, our taxpayers, are not paying by far the highest prices in the entire world, even as we finance through the NIH and through some private investment, the research that's being done. So I strongly support this. It's a really good bill, and it's in addition to the steps we've taken. But let's not get too satisfied until we actually can get the price that our consumers pay much more in line with what consumers in Europe and in many other parts of the world pay. So I yield back and congratulate the authors of this legislation and thank the chair and the ranking member.
Both for his comments and for his work. Are there any other members that would like to speak to the amendment? The gentleman from Georgia, Mr. Carter, is recognized.
Madam Chair, move to strike the last word. Let me assure my colleagues that this is far from finished. This is a good bill, and it's certainly going to help. But we've got a lot more work to do on this particular subject. So I appreciate it, but I'm so encouraged by the bipartisan work that's going on here, and I look forward to continuing this work in the future as well. And I yield back.
Gentleman yields back. Are there any members on the Democratic side that would like to be recognized to speak on the amendment? Since there, I don't think there are there? No. Are there any members who seek recognition to offer any other amendments to the amendment in the nature of the substitute? If there's no further discussion or amendments, we'll proceed to a vote on the amendment in the nature of a substitute. All those in favor of the amendment in the nature of a substitute to H.R. 2296 will signify by saying aye. Aye. All those opposed, in the opinion of the chair, the ayes have it. The amendment in the nature of a substitute to H.R. 2296 is agreed to. The question now occurs on favorably forwarding H.R. 2296 as amended to the full committee. All those in favor of favorably reporting H.R. 2296 to the full as amended will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. H.R. 2296 as amended is forwarded to the full committee. The chair now will begin consideration of the bills. The chair calls up H.R. 2328, the Chime Act of 2019, and the clerk will report the title of the bill.
H.R. 2328, a bill to reauthorize and extend funding for community health centers and the National Health Service Corps.
Without objection, the first reading of the bill will be dispensed with. The bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. The chair will now recognize Mr. Butterfield to offer an amendment in the nature of a substitute.
Madam Chair, my amendment should be at the desk.
The clerk will what is your amendment labeled, Mr. Butterfield? You have it?
It's amendment in the nature of a substitute to H.R. 2328.
Excellent. The clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 2328 offered by Mr. Butterfield. Strike all after the enacting clause.
Without
and insert
objection, the
following.
reading of the amendment will be dispensed with, and Mr. Butterfield is now recognized for 5 minutes.
Thank you, Madam Chair. Madam Chair, my amendment is a substitute to our colleague, Mr. O'Halloran's bill, now before us, H.R. 2328. It will extend a number of public health and Medicare programs, and so I would like to address just a few of those if I can. I have long championed both community health centers and the National Health Service Corps, which is why I was a co-sponsor of H.R. 1943, the Community Health Center and Primary Care Workforce Expansion Act, introduced by our friend Mr. Clyburn. The amendment I offered today will provide 4 years. That's 4 years of stable and predictable funding for vital programs that serve our nation's most vulnerable, including community health centers and the National Health Service Corps. As my colleagues know, long-term funding is very, very important for programs like these, and I'm glad to offer an amendment that will provide the financial resources that are absolutely necessary to meet the health service needs in our underserved communities, including those in my district that is home to 9 federally funded health center organizations and 52 Service Corps sites. As I discussed in our hearing last month, 2 years ago, a federally qualified health center in my district lost out on recruiting a new doctor because the physician was concerned that the health service funding would not be renewed. Service Corps funding would not be renewed. This is a perfect example of why the long-term investments in these programs provided in my amendment are so critical. My amendment also provides extensions for many other important programs, but I would like to note how pleased I am that it provides 4 years of funding for the special diabetes program. I know many of my colleagues have an interest in that. Yesterday, I had the pleasure of meeting with a young lady from my district, Ella, who has type 1 diabetes. Ella reiterated to me and to my staff how important long-term and predictable funding is for special diabetes programs. And I'm proud that we are providing stable funding for this important program. My amendment provides long-term funding for programs that all of you care about deeply and are vital to our constituents. And so I urge my colleagues to support this amendment to ensure that these programs have long-term, predictable, and necessary funding. And as I close, Madam Chair, I want to say that I appreciate your leadership and the leadership of the ranking member of both the subcommittee and the full committee for your cooperation, and most importantly, for your bipartisanship in making it possible to pass these pieces of legislation today. I yield back.
The gentleman yields back. We appreciate his wonderful comments. The chair recognizes Dr. Burgess for 5 minutes.
Thank you. This package does include public health reauthorizations that are vital to every one of our communities, and I am supportive of the effort to reauthorize these programs for an additional 4 years. This also includes a 3-year reauthorization of the Independence at Home demonstration program, which was created in 2010 as a Center for Medicare and Medicaid Innovation demonstration. This program provides home-based primary care to high-need Medicare beneficiaries with multiple chronic conditions, helping them to avoid unnecessary hospitalizations, emergency room visits, and nursing home admission. The purpose of the demonstration is to improve seniors' access to quality health care and to provide it in the comfort of their own homes, and to lower costs and improve quality along the way. I have introduced this program along with Debbie Dingell, most recently in H.R. 3644, which is included in this package. I look forward to continuing to work with Representative Dingell in allowing this demonstration project to proceed and to continue to collect positive data. The Medicare extenders included in this bill are each for 3 years, which will align the authorizations with those included in the Bipartisan Budget Act of 2018, putting them all on the same reauthorization cycle. I therefore urge all members of the subcommittee to vote in favor of this critical reauthorization package and the amendment offered by Mr. Butterfield.
Would the gentleman
I'll
yield?
be happy to yield to the...
If I could just jump on your time a second here and just concur in everything that's been said by the committee. I'm really pleased we've got this longer extension on community health centers and special diabetes programs, and it's really important work, and I commend everybody on the committee getting this done. So I yield back to the chairman.
The gentleman yields back. I'll recognize myself to strike the last word and to make some comments about the amendment and the nature of the substitute, which I thank Mr. Butterfield for making. I'm not going to repeat all the wonderful things that have been said about this, except to highlight something, and that is that community health centers provide primary care to 1 in 13 Americans, regardless of their ability to pay. I think without these community health centers across the country, especially in the rural areas of our country, urban and what I call frontier communities, these communities would collapse in terms of having the health care that they need. And so much of it starts with the open door of primary care. So I'm thrilled about the extension and that it is 4 years. I hope the next time we do it for 5 years, that we just keep climbing the ladder. And the other programs that we're extending, whether it's diabetes or DISH, the Patient-Centered Outcomes Research Institute, and the strengthening of Medicare through stronger enrollment support for low-income beneficiaries, that's going to help a lot of people. And the independence at home, look, a lot of us are past the middle of our lives. No one raises their hand and said, I'd like to go elsewhere. Everyone wants to be at home. So these in-home, the independence at home, and the dollars that it saves. CMS recently analyzed the program and said that that it saves over $16.3 million, an average of $1,431 per patient. So it's not only designed right, the price tag is low. So I think it's a win-win across the board. And with that, I will yield back. Are there other members that would like to speak to? We're on this side now? Yes. The gentlewoman from Indiana. What? Is Mr. Bilirakis first? Yeah, he has more seniority. Yeah, I'm told you have more seniority. Is that why we sit up here?
I like it, yeah. No, I don't have an amendment.
The chair recognizes the gentleman from Florida, Mr. Bilirakis, for 5 minutes.
Thank you, Madam Chair. I appreciate it. I'd first like to thank my colleague and co-chair of the Rare Disease Caucus, Representative Butterfield, for offering this amendment in the nature of a substitute. H.R. 2328, also known as the Reauthorizing and Extending America's Community Health Act, or the REACH Act. This bill reauthorizes several important public health programs, including community health centers, something very important to me and many of my constituents. My father, Congressman Mike Bilirakis, worked on this issue for many years. I'm very pleased to see a substantial reauthorization of this critical community lifeline. Community health centers have a proven track record of providing high-quality, cost-efficient health care to approximately 28 million Americans, predominantly from low-income and vulnerable backgrounds. In fact, community health centers treat 1 in 5 uninsured Americans, a third of these living in poverty, and 1 in 6 Medicaid beneficiaries. Community health centers provide high-quality, cost-effective care that annually saves the healthcare system an estimated $24 billion by reducing the need for patients to seek care in costlier settings, such as emergency departments. I've witnessed impressive innovation and collaboration as the community health centers in my district, like Premier Community Health Center and Community Health Center of Pinellas, work with other community partners to provide a system of care that is accessible and cost efficient. Community health centers have long enjoyed bipartisan support because they are a prime example of what is working in our healthcare system. In fact, I believe they offer a framework for efficiency that can be useful as we tackle the broader challenges within our healthcare system. Additionally, the bill reauthorizes several valuable Medicare programs, such as the Patient-Centered Outcomes Research Trust Fund, which is reauthorized for 7 years and makes minor changes to the Patient-Centered Outcome Research Institute's national research priorities to include substance abuse, mental health, and maternity morbidity and mortality, and critical public health issues. I've heard from my constituents about the importance of PCORI-funded research and building the evidence base for informed health decisions to empower patients and to drive healthcare innovation. In the state of Florida, PCORI supports the groundbreaking program One Florida a statewide clinical research partnership between the University of Florida, my alma mater, the University of Miami, Florida State University, and the University of South Florida. Major health systems in Florida, health plans, providers, and patients. This partnership allows researchers, clinicians, patients, and other stakeholders to address some of the biggest healthcare challenges, including conducting studies focused on more accurately treating hypertension, heart disease, prostate cancer, and hepatitis C. The ability to provide personalized care discourages ineffective and low-value care and generates evidence-based, evidence patients. And for this, and again, for those who care for them, they can use that better informed health care to make those decisions. I've also been impressed with the PEDSnet, a PCORI-supported cross-institution pediatric research network, which includes 8 pediatric research institutions, including one that has clinics in my district. I still have a little time here. Leveraging data from close to 20 million medical encounters with over 500,000 children, the PEDSnet partnership recently publicized a study that shows how to prevent 1 million cases a year of new onset asthma, so important. The study demonstrates that obesity is the only preventable risk factor for asthma. In order to improve care and address the rising cost of healthcare spending in this country, we need to look at practical solutions that are both evidence-based and patient-centered. I urge my colleagues to support this important piece of legislation, and I yield back, Madam Chair. Thank you so much.
The gentleman yields back. Thank you for your comments. Who on the, let's see, what's the lineup here? The chairman of the full committee, Mr. Pallone, is recognized.
Thank you, Madam Chair, for your leadership, and I want to thank Mr. Butterfield for offering this amendment in the nature of a substitute. His amendment will allow patients and healthcare providers to have the certainty of a long-term extension of funding. As we heard at our hearing, the threat of a lapse in funding prevents our community health centers, teaching health centers, and medical professionals working as part of National Health Service Corps from planning and fully investing in care for their patients. When the Community Health Care Center Fund was created as part of the Affordable Care Act, Congress was able to increase the number of community health centers from 8,000 to over 12,000 today. And as community health center capacity has grown, more patients have been able to access care. The reauthorization we're passing today represents the longest extension of the fund since it was created, with the most robust funding on record. This amendment will also help bolster the future of our healthcare workforce and underserved communities by extending funding for the National Health Service Corps and the Teaching Health Center Graduate Medical Education Program. The National Health Service Corps program provides financial support to professional students and primary care providers who commit to serve in medically underserved communities in urban, rural, and tribal areas. The Teaching Health Center program has similarly increased training of primary care medical and dental residents in community-based settings, such as community health centers and rural health clinics, and physicians trained at teaching health centers are far more likely to practice in a medically underserved or rural community. In addition, this amendment extends family-to-family health information centers, which help children with medically complex cases, and the Special Diabetes Program, which provides important research and treatment funding for those with type 1 diabetes and members of the Native American community diagnosed with diabetes. So Mr. Butterfield's amendment extends funding for Medicare programs that improve access to quality care for low-income beneficiaries, including funding for enrollment outreach and funds to help low-income beneficiaries access prescription drugs through Medicare Part D. Additionally, the amendment continues the very successful Independence at Home Medicare Demonstration Program and the Patient-Centered Outcomes Research Institute. So all of these provisions put patients first and improve access to care, and I want to thank all our members for supporting. Thank you, Madam Chair. I yield back.
The gentleman yields back. I just want to say to members, here's a little vitamin B shot. After we complete the work that we're doing on this with its amendment, we have 2 more bills to go, and I don't anticipate at this time that there are amendments to it. So hang in there. All right. Let's see. Dr. Bouchon? No? Then the chair is pleased to recognize the distinguished gentlewoman from Indiana, my pal, Ms. Brooks.
Thank you, Madam Chairwoman, and thank you to Ranking Member Burgess and Representative Butterfield for offering the amendment. I'm so very pleased that we have come to this bipartisan agreement on H.R. 2328, in particular because it extends funding for community health centers for 4 years, far better than the 2 years previously authorized. And I also think it's critically important that we continue to show the American people that we want to provide that stability and security to community health centers. Just this week, I participated in a ribbon-cutting event in Indianapolis at a new Jane Pauley Community Health Center on the northeast side of Indianapolis. That's right, Jane Pauley, the CBS Sunday News morning anchor, has given her name and the level of importance to our community health centers in central Indiana, of which we have many. And so this award-winning television journalist very much believes in what the mission of community health centers is about. And this new beautiful facility, in a former grocery store, by the way, provides incredible opportunities for family medicine, pediatrics, behavioral health, OBGYN, and dental services. These critical services, both primary and preventative care to people who need it, would not otherwise be available and accessible. And in my district, in central to northern Indiana, more than 80,000 Hoosiers rely on community health centers to access needed care. Right now, we know that if they get this quality, affordable, convenient health care, it puts patients and our neighbors, quite frankly, in a better position to find and keep good jobs, to make sure their children get that stronger start in life, and to prevent chronic and debilitating illnesses. As rates of diabetes and heart disease continue to rise, and while we still know that we've not overcome the heroin opioid epidemic, the work of these centers is even more critical to the continued health and wellness of Hoosiers and Americans. And speaking of diabetes, I'm especially pleased that also this bill includes reauthorization of the special diabetes program for 4 years. I must say that I, too, had a constituent and a young woman named Ella Hudzamir from Fishers, Indiana, who visited me yesterday, an 11-year-old who lives with type 1 diabetes. And she shared with me as part of the JDRF Children's Congress that diabetes research has changed her life dramatically. She was diagnosed at age 4. At that time, she and her parents were pricking her fingers 10 to 15 times a day to carefully manage her disease. And now, because of the investments in the special diabetes program, she no longer has to prick her fingers. She has those 2 very special small machines taped to her arms, one that monitors her glucose and one that administers her insulin. And this type of innovation is what's so critical to allow Ella to live a much more normal life. And so Ella Hudzamir and all of the other young people who came in to talk with us about the special diabetes program, we thank them. And we also want, and I want to show them, and I'm so appreciative that in this bipartisan way, we are helping the innovators pave the way, and with eventually, we will find a cure for this very, very difficult chronic disease. With that, I will yield back the balance of my time, and I thank everyone for coming to agreement on this critical bill.
Thank the gentlewoman, and she yields back. The chair Mr. Welch.
Did you want to speak?
The chair recognizes the gentleman from Vermont, Mr. Welch, for 5 minutes.
Thank you. I appreciate the amendment of Mr. Butterfield. All of us are very concerned about the well-being of the community health centers. We have 11 in Vermont, 68 sites throughout the state. They provide vital access there, as they do elsewhere, to low-income Vermonters. They serve 172,000 Vermonters, and that is with services from primary care to dental care to substance abuse treatment. So this is tremendous to provide stable funding. That means everyone can count on those funds and plan accordingly. I do want to raise a question for the consideration of the committee between now and the full committee, and that is the $4 billion annual authorization. The good part is secure and solid. The question is its level funding, and that has real impacts, and we can't disregard that, because by 2024, by having level funding, that in effect, when you account for inflation and when you account for population increase, is really a 20% reduction in what would have been the funding had we kept on the same trajectory. So I'm hoping, and that has real impacts. It might be across the country about 212 fewer community health centers, 4.2 million fewer people served, and that's significant. So my hope is that we can work together with the Chairman Pallone and Chairwoman Eshoo and Ranking Members Burgess and Walden to find a way forward to increase that funding so that it really is level, adjusted for inflation and adjusted for population increases, because that means that the same level of service that they're providing now, they'll be able to provide
The gentleman yield.
in 2024. I will yield, yes.
I appreciate your words, Mr. Welch, and this is identically my concern as well. But in the spirit of bipartisanship and trying to get this legislation to the full committee, I think we ought to agree to full flat funding right now at $4 billion, and as it goes along, maybe we can plus it up some.
Well,
so thank you for your words. I agree with you.
Yeah, and I appreciate you saying that, and I do intend to support this, and I really appreciate your work and leadership on this. But it's also important for the committee to acknowledge that level funding does have consequences on delivery of services. I yield back.
The gentleman yields back. Anyone on the Republican side? Democratic side? The chair is pleased to recognize Dr. Ruiz of California for his 5 minutes.
Thank you, Chairwoman. Thank you for including the extension of the Teaching Health Center program in this amendment today. I would like to thank my colleague, Congresswoman McMorris Rodgers, for introducing the Training the Next Generation of Primary Care Doctors Act with me and working to extend and expand this critical program. The Teaching Health Center program is a critical component to addressing our physician shortage. Research that I conducted before I came to Congress showed that in my region, in Southern California, Eastern Riverside County, there was only one doctor for every 9,000 residents, 3 times the recommended ratio. This means far too many patients cannot get in to see their doctor or don't live in an area with enough primary care physicians. Research also shows that when physicians train in underserved areas, they are more likely to stay or practice in underserved areas. Additionally, when they train in rural communities and see the specific and unique health needs facing underserved areas, they are better equipped to serve in those areas. That's why the Teaching Health Center Graduate Medical Education Program was created, to directly train primary and dental care residents directly in community health centers where they're needed the most. It helped create an infrastructure to house residents in the places where they are needed and encourage them to return to serve there. And it has been successful, creating more than 700 residency slots in nearly 60 health center programs. 2017 data collected by the American Association of Teaching Health Centers shows that 82% of THC graduates remain in primary care practice, compared to only 23% of traditional GME graduates. 55% of THC graduates practice in underserved communities, compared to only 26% of traditional GME graduates. 20% of THC graduates practice in rural America, compared to only 8% of traditional GME graduates. I know that stable funding is important for the function and planning of these programs. So I'm thankful for the members of this committee on both sides who understand the importance of this program and included funding for twice as long as our last reauthorization. Of course, given the success of the program and the physician shortage our country is facing, and I'm concerned will get worse, I will continue to work to expand the program as well, so that even more communities will be able to benefit from its success. So if you want more primary care physicians, and you want them to practice in rural and underserved areas, then this is an excellent model that we must invest in order to achieve the health disparities and the inequities that we see throughout our country. We have a very serious and urgent problem in the lack of physicians and the lack of adequate workforce in healthcare in our country. And when you live in underserved areas like I have and I grew up in, oftentimes you don't have the right specialist, you don't have the right physician, and you're left to go to the only emergency department in the area for primary care or something that could be addressed by a primary care physician. That adds to the pain, to the suffering that our patients, our family members, and our communities face day in and day out, and particularly in underserved and rural communities. We must do more to expand GME in our country and redistribute with incentives so that they practice in areas where they are needed the most. If we don't do that, we can create all the access that you want. We can expand all the insurance programs that you want, which I am fully in favor for. But if you don't have the workforce to see newly insured individuals or people who need them, then you're not achieving full access to care that we need in our country, particularly in communities that face higher disparities of morbidity and mortality simply because of their zip code. So I look forward to working with my colleagues on this issue, as well as other policies that will help address our growing physician shortage in the coming months. Thank you, and I yield back.
Are there any other members seeking recognition on this amendment? Ms. Dingle?
Thank you, Mr. Chair. I move to strike the last word and speak in favor of this legislation.
Minutes.
Thank you, Mr. Chairman. I'm pleased to support this amendment, which includes two bipartisan provisions I've introduced. First, this amendment includes language from H.R. 3421, the Fair Choices for Medicare Beneficiaries Act, which I introduced with Representatives Gomez and Buchanan. This bill reauthorizes 4 highly successful Medicare outreach programs for 3 years. Specifically, these 4 programs are the State Health Insurance Assistant Programs, Area Agencies on Aging, which do such good work, the Aging and Disability Resources Center, and the National Center for Benefits Outreach and Enrollment. Each of these programs helps to strengthen Medicare and ensure it works for everyone, and they're all so important to seniors. In addition, this amendment includes language from H.R. 3644, the Independence at Home Demonstration Act, which I introduced with Ranking Member Burgess, and I'm very honored to work with him on many different bills. This provision extends, as has been discussed by others, the successful Independence at Home demonstration for an additional 3 years, which will allow more Medicare beneficiaries to receive primary care from their own homes. The Independence at Home program has a proven track record of helping people get the care they need, and it saves dollars, pure and simple. And shouldn't somebody have a happy senior end-of-life experience if they can, rather than institutionalizing them? So this is an important program, and then I want to associate myself with my colleague, Mr. Welch's comments. I really want to thank the chairman for introducing this bill and giving us stable funding. It is critical to have stable funding. Unfortunately, stable funding really can mean at the end of 4 years a 20% reduction. And these programs are all so important. So if we could all work, we all want to be bipartisan on this, but every one of these programs in here is bipartisan, matters, and we've got to make sure that they've got the ability to deliver them in the communities that they need. I urge my colleagues to support this legislation and yield back the balance of my time.
The gentlewoman yields back, and the gentlewoman is correct. $4 billion today is not $4 billion tomorrow. Are there other members seeking recognition to speak on the amendment? Ms. Barragan is recognized for 5 minutes.
Thank you. I move to strike the last word. I'm pleased that the Improving Low-Income Access to Prescription Drugs Act has been included in this markup. I was proud to introduce this legislation with Congressman Olson, Marchant, and Lewis that would make the Medicare Limited Income Newly Eligible Transition Program permanent. This demonstration program, which began in 2010, provides temporary Part D prescription drug coverage for low-income Medicare beneficiaries not already in a Medicare drug plan. This program has been incredibly successful in the past 10 years, saving $300 million and making sure beneficiaries get access to medication. By making the LINET program permanent, we can continue to provide transitional prescription drug coverage for those with low incomes. I look forward to advancing our work to help all Americans get the medications they need. I also want to take a moment to offer my support for reauthorizing the Patient-Centered Outcomes Research Institute and the PCOR Trust Fund. As we heard during last month's extenders hearing, PCOR's clinical comparative effectiveness research empowers patients, clinicians, and families to make more informed decisions about their own health care. I look forward to continuing to support PCOR and ensuring it has the long-term support it needs to continue this vital work. I want to thank the chair for including this reauthorization in the extenders package and encourage all members to support it as well. And with that, I yield back.
Gentlewoman yields back. Are there other members seeking recognition to speak on this amendment? Ms. Blunt, Rochester.
Thank
For
you,
what
Mr.
purpose do you seek recognition?
I move to strike the last word.
Gentlelady is recognized for 5 minutes.
Thank you, Mr. Chairman. And also, I'd like to thank you for your leadership in offering this amendment to, in the nature of a substitute, and also the other members of the committee that have worked on these important extenders. As Marian Wright Edelman, the founder of the Children's Defense Fund, once said, "The best contraceptives are hope and a sense of a positive future." This committee has found a bipartisan way to deliver hope and a positive future to young men and women across the country with the reauthorization of the Personal Responsibility Education, or PrEP program. This program translates beyond just informing adolescents about how to make informed and responsible decisions about their health. The good news is that the U.S. teen pregnancy rate has declined since the 1990s. But in this age of multiple and competing pressures on youth and social media, we must support adolescents even more by equipping them with decision-making tools. Research shows there is a strong correlation between teenage pregnancy and poverty, inadequate health care, and low-income jobs. The PrEP program provides more than education about making healthy decisions. It provides hope and a positive economic future for teens who are maturing into adults. The PrEP program is an opportunity to teach young adults about how to plan for their future and how to make choices that will allow them to pursue all of their hopes and dreams. At its core, the PrEP program funds evidence-based programs that educate youth about healthy decision-making to lower teen pregnancy rates and reduce sexually transmitted infections. The program also focuses on teaching financial literacy and strategies for building healthy relationships, skills that are crucial for young adults thriving as members of our society. Delaware's PrEP funding has ensured that 1,400 to 1,900 vulnerable at-risk students per year participate in one of 2 vigorously tested programs. By targeting vulnerable and at-risk youth, my state's PrEP programs apply an evidence-proven framework that empowers adolescents to be proud and responsible. The PrEP program also operates in community-based settings, which allows for adolescents and their parents to have meaningful conversations about sexual responsibility. I was proud to learn that my state even took extra steps to make their program as inclusive as possible by training a teacher at the Delaware School for the Deaf using American Sign Language interpreters who can educate students who are deaf or hard of hearing. Delaware's PrEP program has also made great strides in being inclusive of LGBTQ youth. PrEP also goes beyond just sexual education. In one state, a PrEP grantee offered youth intimate partner violence training to teach teens about healthy relationships, teen dating violence, peer pressure, and goals. These students could then promote their understanding of healthy relationships among their classmates to build a safer environment for all students. This is just one example of the many success stories of PrEP across the country. Extending funding for PrEP for more than 4 years will provide states, tribes, and communities with greater certainty to plan and serve young people without disruption. I am proud to have introduced the PrEP Reauthorization Act, and I'd also like to thank the members for their bipartisan work on PCORI, the Patient-Centered Outcomes Research Institute. And I'm hopeful that this work will also become more of a long-term reauthorization. I ask my colleagues to join me in supporting all of this bipartisan legislation, and with that, I yield back the balance of my time, Mr. Chairman.
Gentlewoman yields back. Are there other members seeking recognition to speak on the amendment? Mr. Schrader, for what purpose do you seek recognition?
To speak to the bill, underlying bill.
The gentleman is recognized for 5 minutes.
I want to offer my support, along with others, for the reauthorization of the Patient-Centered Outcomes Research Institute. Thank the chair and the ranking member for including this provision in the package today. Last month, we heard from Dr. Lisa Cooper at our hearing on extenders that PCORI is doing some great work supporting research that matters to patients and clinicians and producing great results that'll hopefully have a major impact on improving health outcomes for patients and our health system overall. As an original co-sponsor of the legislation creating PCORI 10 years ago, I'm pleased to see how far they've come. But I'm also interested in how much more we can accomplish and where they go, particularly looking at options to address rising prescription drug costs and how we can drive real value in our healthcare system, including, hopefully, eventually, cost-benefit analysis to give patients the best value for the dollar. I look forward to continuing to work with Congresswoman DeGette, who has been a leader in PCORI's reauthorization efforts, as well as Congressman Beyer and Reed, who've done a lot of work in Ways and Means on how we can ensure PCORI continues to meet its mandate and serve as a valuable resource to our health system. And again, I want to thank the chair and the ranking member for including this provision in the extenders discussion. Urge my colleagues to support it as well, and I yield back.
Thank you. The gentleman yields back. Are there other members seeking recognition to speak on this amendment? For what purpose does Mr. Rush seek recognition?
Mr. Chairman, I move to strike the last word.
The gentleman is recognized now for 5 minutes.
Mr. Chairman, I am pleased that your amendment in the nature of a substitute includes a number of critically important provisions. It is absolutely critical, Mr. Chairman, that we fund our community health centers adequately and that we ensure funding for all other life-saving programs that are up for reauthorization this coming September. That said, Mr. Chairman, I'm also proud that a bipartisan bill I have worked on with my friend Representative Bouchard, the Prostate Cancer Misdiagnosis Elimination Act, is included today as part of the HEARTS Act. Mr. Chairman, 1 in every 200 patients reportedly receives a clinically significant misdiagnosis due to either biopsy tissue switching or contamination errors. These errant diagnoses can lead to radiation and other unnecessary treatments for otherwise healthy patients, as well as the postponement of treatment and subsequent worse health outcomes for patients with cancer who do not even know that they are sick. The Prostate Cancer Misdiagnosis Elimination Act provides Medicare coverage for a DNA test known as the DNA DSPA for positive cancer biopsies. This legislation will ensure that if a biopsy is mixed up, the healthy individual does not receive unnecessary treatment and the sick individual is appropriately and immediately identified. Currently, Mr. Chairman, an estimated 1 in 41 Americans will die from prostate cancer each year. We must ensure that all patients receive the correct diagnosis so that the right patient receives the right treatment at the right time, and that is as quickly as possible. This bill will do just that. I want to once again thank my friend from Indiana, Mr. Bouchard, as well as the House sponsors, Mr. Thompson and Mr. Ferguson, for their work on this important bill. I want to also thank the chairman, Mr. Pallone, the chairman of the Health Subcommittee, and all the other important individuals for their work on this particular bill. And I urge my colleagues to support the amendment in the nature of a substitute, and I yield back the balance of my time.
Thank the gentleman. Is there anyone on the Republican side? Dr. Bouchon is recognized for 5 minutes.
Yeah, move to strike the last word. I just want to associate myself with Mr. Rush's comments on the prostate legislation and look forward to getting that signed into law. I yield back.
Thank the gentleman. Is there anyone on the Democratic side? Mr. What?
I'm sorry. I have the amendment. Yes. Okay.
We're still on this. Hopefully we're done. Are there going once, going twice, going 3 times? I don't see any other members who seek recognition to offer an amendment to the amendment. So who does? Mr. Kennedy.
Yes.
For what purpose does the gentleman seek recognition?
Madam Chair, I have an amendment to the amendment.
What is your amendment labeled?
Yes, it's SC AMD 01.
Excellent. The clerk will report the amendment, please.
Amendment to the amendment in the nature of a substitute to H.R. 2328 offered by Mr. Kennedy of Massachusetts. Page 25 after line 7.
Without
insert.
objection, the reading of the amendment will be dispensed with. And the gentleman from Massachusetts recognized for 5 minutes to speak to his amendment.
Thank you, Madam Chair. I will not take all 5 minutes, I promise. I have a bipartisan amendment along with Mr. Engel, and I want to thank him specifically for his leadership and work that he put into making this amendment happen, along with Mr. Hudson and Mr. Long. And I want to thank Mr. Olson as well for the work that he put into the legislation. I'm proud to be offering an amendment to the amendment in the nature of the substitute to eliminate the DISH cuts for fiscal year 2020 and 2021 and to lower the reduction from $8 billion to $4 billion in 2022. If the cuts go forward, it could mean a loss of over $315 million for Massachusetts, and this bipartisan amendment will ensure that disproportionate share hospitals can continue to serve low-income patients nationwide. Their work is a critical part of our healthcare system, and I urge my colleagues to support the amendment, and I yield back.
The gentleman yields back. The gentleman from North Carolina, Mr. Hudson, is recognized for 5 minutes.
Thank you, Madam Chair. First, I'd like to thank my friend, Mr. Kennedy, for working with me on this amendment that is so critical to North Carolina's hospitals. I'd also like to recognize the lion of DISH cuts, Mr. Pete Olson of Texas, for his dedication to solving this problem. This amendment would delay the DISH cuts by another 2 years. The DISH cuts were implemented through the Affordable Care Act to offset the cost of Medicaid expansion. North Carolina did not expand Medicaid, and therefore these cuts have loomed over our hospitals as a threat of even lower reimbursements without the carrot meant to replace them. This amendment also includes reporting requirements for hospitals to provide more data on how supplemental payments are used and a GAO study on options to update the outdated formula. Our hope is through all these tools, we're giving hospitals the opportunity to work with us on finding solutions to the DISH cuts and think through options for improving the DISH formula. I want to thank my colleagues, again, Mr. Kennedy, Mr. Engel, Mr. Olson, and Mr. Long for their work on this important amendment, and I encourage all my colleagues to support it. Madam Chair, I yield back.
The gentleman yields back. Are there any other members that would like to speak to the Kennedy amendment? The gentleman from Vermont, Mr. Welch, is recognized for 5 minutes.
Well, I strongly support it and thank all who have been involved in this. And it's an interesting group of us who all are concerned about access to health care, particularly in rural America. Those small hospitals in particular are under enormous pressure, and those local institutions are really, really critical to the well-being of a rural America that is under siege. So I applaud my colleagues who took the lead in giving relief to our hospitals so that they have a chance to fight another day. I yield back.
The gentleman yields back. Is there anyone else on the Republican side that would like to speak? Okay. On the Democratic side, Any members that would like to speak to the amendment? There's no further debate. We'll proceed to a vote on the amendment. All those in favor of the amendment signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. The amendment is agreed to. Are there further amendments to the amendment in the nature of a substitute? If there's no further discussion or amendments, we will proceed to a vote on the amendment in the nature of a substitute introduced by Mr. Butterfield. All those in favor of the amendment in the nature of a substitute to H.R. 2328 will signify by saying aye. Aye. All those opposed? None. In the opinion of the chair, the ayes have it. The amendment in the nature of a substitute to H.R. 2328 is agreed to. The question now occurs on favorably reporting H.R. 2328 to the full committee. All those in favor of forwarding H.R. 2328 as amended will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. H.R. 2328, as amended, is favorably reported to the full committee. Okay, we're moving. The chair now calls up H.R. 3631, the Territories Health Care Improvement Act, and the clerk will report the title of the bill.
H.R. 3631, a bill to amend Title 11 and 19 of the Social Security Act to provide for a temporary increase in the limit on
Without objection,
Medicaid.
the first reading of the bill will be dispensed with, and the bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any time. Are there any members who seek recognition to offer an amendment? Seeing none, the question now occurs on favorably forwarding H.R. 3631. Whoops,
We want to
whoops.
speak on it.
Yes. The chair is happy to recognize the chairman of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Madam Chair. The subcommittee recently heard directly from representatives from the territory's Medicaid programs about the dire financial situation they're facing in just a few months if we fail to act. And I know, Madam Chair, you specifically mentioned to me how I think it was the first time that at the hearing on this bill that we had delegates, or I should say representatives from all of Puerto Rico and all the territories actually testify at the hearing. In addition to that, we had the delegates from each of the, not only from Puerto Rico, Ms. Gonzalez, but from each of the territories present at the hearing, which I thought was a first. So I think we really got some good input. I also wanted to thank again Mr. Walden because he led a CODEL, which I also participated in after Hurricane Maria, which I thought was very thoughtful in giving us information, not only from a representative or Gonzalez, but from everybody, the governor, about what the situation there was. And we've also had a lot of input on this, not only from Mr. Soto, but other members of Congress who are of Puerto Rican descent, who've taken a lot of interest in this. I want to mention Ms. Velasquez in particular, but the others as well. So, I mean, we all know that the territory's Medicaid program doesn't operate like state programs. They receive a capped amount of federal dollars every year, and any Medicaid costs over the cap are paid for with only territory dollars. And that's an incredible burden under normal circumstances and absolutely devastating during an economic downturn or a natural disaster like Maria, when spending on Medicaid typically increases. So this legislation would provide the territories with several years of increased federal funding and increased matching rate. And with these increased federal dollars, the territories will be able to provide people with the health care they need, increase payments to doctors and hospitals, and expand benefits. I should mention also, Mr. Walden, that that CODEL also included the Virgin Islands. It wasn't just Puerto Rico. So we met with Stacy and went to some important places in the Virgin Islands as well. But this bill makes important program integrity improvements in each of the territories. By holding the territories to the same standards that we hold state Medicaid programs, the bill will help ensure that federal Medicaid funds are serving their intended purpose of providing health care to the people who need it. So I did want to thank in particular Representatives Soto and Bilirakis for their leadership on this important legislation. I think the proposal they put together is a thoughtful, reasonable approach to address the Medicaid cliff in the territories. And again, all of us, I think, are putting, we still want to come up with a permanent solution, but we're talking 4 to 6 years here, depending on whether it's Puerto Rico or the territories. And, I'm very proud of the fact that even though we're not doing a permanent solution today, we're certainly doing a long-term solution that makes a big difference. So thank you, Madam Chair, and I yield back.
The gentleman yields back. The chair recognizes the ranking member of the full committee, the gentleman from Oregon, Mr. Walden, for 5 minutes.
Thank you, Chair. I appreciate that, and I'm thankful to you and to Chairman Perlone for partnership and willingness to work together to put forward a bold package that will ensure the territories' Medicaid programs are adequately funded and that these programs will have program integrity measures in place. This heightened accountability is critically important to ensure these dollars actually go to the people who need them most. However, given the news yesterday out of Puerto Rico, we will also need additional program integrity measures in place before we advance this bill out of full committee. I'm committed to that work, and I look forward to working with the majority on what steps we can put in place to stop these types of fraudulent activities that are alleged from happening again. And I would yield.
Gentleman
to the
yield.
Gentleman from New Jersey.
Representative Walden, the news from Puerto Rico yesterday regarding the alleged misconduct of individuals responsible for overseeing the Medicaid program is obviously very troubling. And I know that we both take very seriously our role in overseeing the Medicaid program and ensuring that federal Medicaid dollars serve their intended purpose of improving health care for beneficiaries. While the allegations are serious, I want to be clear that there's no indication that Medicaid beneficiaries in Puerto Rico did anything wrong. In fact, if the allegations are true, the beneficiaries are among the victims. Right. So we can't lose sight of the fact that unless we act, there will be a massive shortfall of federal funds for the Puerto Rico Medicaid program that would be devastating to the people who live there. And this news, as you know, broke yesterday, and we're still learning the details of the allegations. There wasn't time for us to address the issues raised by these allegations in the underlying bill. And while the bill we're considering today makes some important improvements to program integrity in Puerto Rico, I think it's clear that we need to do more. So I just wanted to say, given the gravity of the situation facing Puerto Rico, if we fail to provide additional federal funds, but also the seriousness of these recent allegations, it's my hope that we can work together to achieve a bipartisan consensus that provides these much-needed funds, but also ensures the rigorous program integrity and oversight necessary to ensure that federal funding is used to improve health care for Medicaid beneficiaries. Can I just say, are you willing to commit to working with us to provide these increased funds and also further strengthen program integrity in the island?
I thank the chairman for his commitment to add more program integrity measures to ensure that this type of fraudulent activity is prevented from happening again. What I frankly find so frustrating about this is exactly what you said, Mr. Chairman. This type of fraud only hurts the Medicaid beneficiaries, the people who rely on this program. So we know the funding cliff for Puerto Rico. We dealt with this matter in the last Congress. We need to deal with it in this Congress. And we know the problem from all the territories is real, which is why we came together to agree to this bill we're discussing today. We are committed to that work and look forward to working together on the funding or additional program integrity measures to ensure that the people who rely on these programs get the care they need and deserve. So we look forward to working with you as this bill advances. It's the last thing the people of Puerto Rico needed to have happen, and yet we have an obligation to the American taxpayers, as we both take seriously. So with that, Madam Chair, I'd yield back the balance of my time.
The gentleman yields back, and I want to associate myself with what Mr. Pallone said about not hurting the people that are Medicaid recipients. We all have to keep that in front of us, and I want to recognize myself to strike the last word, speak on the underlying bill. I think that for too long, the territories have really struggled with inadequate federal funding for their Medicaid programs because of the federal law caps their funding. I know that there's a real history to this. As close as I've gotten to some of the history is that it was capped in 1984. I don't know what the reason was. I think a tax bill was going through the Congress, and as typical of the Congress, they're always looking to find money. And so it was capped. And the territories receive a fixed federal Medicaid match that's lower than the rate that they would receive if they lived in one of the states, one of the 50 states. And because of these restrictions, the territories routinely run out of Medicaid funds. Now, we heard all the testimony, and it was excellent. And I want to salute the members that have really worked hard on this. Mr. Soto is going to speak to it. When I think of Puerto Rico, I think of Nydia Velasquez, as she always takes to the floor. We wouldn't be taking up the Puerto Rico part of this if she was in opposition. I can tell you that. She'd be rolling over all of us. So she's as tough and as good as they come. So I think that the underlying legislation is marked by two things. First of all, the recognition by Congress that we need to do something about it, A. B, that there's a reauthorization for 4 years and for 6 years. The delegates weighed in. They were here with us when we had the hearing. They've met with members of the committee on both sides of the aisle. And I think that this longer-term fix is going to give the territories what they need the most. And what businesses always ask for, stability and certainty. Stability and certainty. So I think that, as I said to Mr. Pallone earlier this morning, I believe that we're going to have to work on a permanent fix relative to this. But I think today these are really steps in the right direction. The territory shouldn't have an arbitrary cap. It just is, you know what? It's discriminatory. That's what it is. There's a real bias here. If you live in the states, this is what you get. You go to the territories, this is what you get. So I'm glad that we're doing this. I'm pleased that it's bipartisan. I want to salute all the members, the delegates especially, certainly Mr. Soto and others for the work that's done. And let's keep this thing on track and keep it moving, because human beings are depending upon it, and in areas that were ravaged by horrible, horrible storms. So they're more than in a one-down position, and the Congress has to, we're recognizing that. So with that, I yield back my time. Is there anyone on the Republican side that would like to, Mr. Bilirakis? You're recognized for 5 minutes. 5 minutes or less.
I'll try to do
okay.
it less. I'll try to do it as fast as I can, Madam Chair. Thank you. I'd like to strike the last word. I'd like to thank my colleague and co-league on this critical bill, Representative Soto, for the bipartisan way in which this bill has been brought to this committee. And yeah, this is how this committee works, Madam Chair, and I appreciate your leadership and the ranking member's leadership. While yesterday's unfortunate news regarding malfeasance in Puerto Rico underscores the need for strong program integrity measures, we all agree with that, it's also important to note that the biggest victims of this, the American citizens of Puerto Rico, for whom the money and resultant health care was stolen. And what a shame. We'll get to the bottom of it, Madam Chair. These American victims should be held harmless, and we should redouble our efforts to put proper safeguards in place so this malfeasance doesn't happen again. I commend FBI Director Wray and federal authorities for their swift action and look forward to equally swift justice. And as an aside, I look forward to my good friend and constituent, Stephen Muldrow, who was recently nominated by the White House. as the new U.S. Attorney for the District of Puerto Rico, taking office and championing, I can't even talk, the cause of justice on behalf of the constituents of Puerto Rico. While it may be tempting to put the political brakes on this bill due to this unfortunate incident, we must remember that the pending Medicaid fiscal cliff is not only an issue for the U.S. territories, but the United States. It's a U.S. issue here in the mainland. This especially is true with the state of Florida, which is often the first to experience the influx of Medicaid patients from the territories seeking care, placing an additional burden on Florida's Medicaid program, providing network and patient benefits. Unlike the rest of the U.S., the territories have been operating their Medicaid programs under federal funding caps, as you mentioned, Madam Chair, that have failed to reflect the current needs of the Americans living there. Without intervention, over 1.5 million Americans, including many children, could lose their health care. Under this bill, the Medicaid caps are responsibly raised, again, to properly reflect the needs of American patients in the territories. Additionally, the following robust program integrity measures have been added, and I know there will be more added after this incident. All territories must report to Congress annually on how they spent increased Medicaid investment. Like all state Medicaid programs, Puerto Rico will need to have in place an asset verification system in place after 2 years and a payment error rate measurement system in place after the 3rd year. Guam, American Samoa, and the Northern Mariana Islands will need to have in place a transformed Medicaid statistical information system and a Medicaid fraud control unit by the end of the 4th year. The U.S. Virgin Islands will need to have in place an asset verification system by the end of the 4th year. While I believe there's still room for additional program integrity improvements, especially considering the recent events in Puerto Rico, I encourage my colleagues to advance this conversation by voting in favor of today's draft and continue to work with me and Representative Soto, the chairman of the full committee, the subcommittees, the ranking members, to produce and advance the best bill we can out of the full committee to the House floor. I thank you, Madam Chair, and I guess 1 minute and 9 seconds to spare. Thank you very much, and I yield back.
Gentleman yields back. I'm being advised by the committee staff that Mr. Soto can't speak. That's dreadful. Well, can't I ask for a unanimous consent of my colleagues? No? Why? Because everybody will. He's the only one here. No? Well, Mr. Soto, I'm sure that you had beautiful remarks to make. The gentleman is intelligent. He's committed to his work. He does a deep dive on the substance. I know, I sit next to him very often, and I want to thank you for your leadership on this, together with the team of members that you worked with. This is going to make a big difference in human beings' lives. And in my book, that's ultimately how we're going to be judged.
Madam
We're
Chair.
called.
Madam
So
Chair.
I really salute you, and I'm sorry that we have this rule.
Madam
Yes,
Chair, a parliamentary inquiry.
Yes.
Can we admit Representative Soto's statement, his full statement, into the record?
Yes, and we will be glad to have it.
Very good, thank you.
Okay.
Thank you.
What? I'm listening to the chatter at this end. It's interesting and it's complimentary. But thank you, Mr. Soto. Please place your statement in the record. Thank you for spending so much time with us here this morning. Is there any, and this afternoon, is there anyone from either side that wishes to speak to the legislation? If not, The question now occurs on favorably forwarding H.R. 3631 to the full committee. All those in favor of forwarding H.R. 3631 to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. H.R. 3631 is forwarded to the full committee. The chair now calls up H.R. 3633, the No Surprises Act. Let's see, so who has the, are there any amendments? No. There are no amendments to this. The clerk, will report the title of the bill. Thank you.
H.R. 3630, a bill to amend Title 27 of the Public Health Service Act to protect health care consumers from surprise billing practices and for other purposes.
Without objection, the first reading of the bill will be dispensed with, and the bill is now considered as read. Without objection, the bill is considered as read and open for amendment at any point. Are there any members who seek recognition to offer an amendment? No amendments? For what, well, do you have an amendment?
No, I don't think there were
All
any,
right.
Madam Chair.
All right. Since we don't have any, then the chair will recognize the chairman of the full committee for his statement on the underlying bill.
Thank you. Every day we hear news stories about American families being devastated financially and put through the tremendous emotional toll of surprise medical bills. Kaiser Health News even has a series highlighting these shocking bills. This month's Bill of the Month involves a woman by the name of Liv Cannon from Austin, Texas, who received a bill for more than $94,000 for out-of-network neural monitoring services she received while getting spinal surgery. She received this absurd surprise bill despite having selected an in-network surgeon and an in-network facility. And this story and the many others like it highlight a clear market failure. It's obvious that the private sector is not going to fix this problem on its own, and that Congress needs to step in and provide relief to consumers. Fortunately, today we're taking decisive action. Ranking Member Walden and I have worked together to craft a common-sense, bipartisan solution to protect patients from the unreasonable and unacceptable practice of surprise billing. And our legislation would ensure that consumers with all types of private insurance are protected and held harmless from surprise bills. It does this by ensuring that an individual's cost sharing for out-of-network care is limited to what the individual would have paid if the services were provided by an in-network provider. This would ensure that patients are no longer penalized by the provider and the insurer's failure to contract. And I think it's only fair, after all, that this is not the fault of the patient. Providers would no longer be able to balance bill patients for out-of-network emergency services or for scheduled services from providers the patient was not aware would be involved in their treatment. The bill resolves the payment dispute between the provider and the insurer by requiring the insurance company to pay at minimum the median in-network rate for that service in that geographic area. And this would create a predictable, transparent means of resolving these disputes between providers and insurers who have failed to contract. It would also place little to no administrative burden on states, the federal government, or the parties like employers involved in the dispute. The bill also sets the median in-network amount based on 2019 rates and increases that amount with inflation. We incorporated this change to address concerns by providers that there would be downward pressure on rates. We believe this change will give providers more certainty going forward. I think, Madam Chair, this is a good bill that has been made better thanks to the constructive feedback we received from stakeholders since we released our discussion draft back in May. For example, the introduced bill would add surprise billing protections for post-stabilization services and for situations when a patient does not have the option of an in-network provider. It would also require the insurers to do a better job of keeping their provider directories up to date so that consumers can make informed decisions. Unfortunately, not all stakeholders have been as constructive as I would have expected, considering the transparent process that has been laid out. And I've said many times that any viable solution to surprise billing can't result in rising health care costs. Any policy that involves bill charges is not an appropriate solution to surprise billing. Bill charges are set unilaterally by providers. They're not market-based rates, and they can be hiked at any time for any reason. In fact, at our legislative hearing, a hospital witness admitted to me that their charges are not based on economic reality and are simply made up. I couldn't believe when he said it. Any system that pegs reimbursement to charges directly or indirectly will increase healthcare costs and therefore increase premiums. We're here today to make healthcare more affordable for everyday Americans, not to make it more expensive. So the No Surprises Act takes patients out of the middle and holds them financially harmless from surprise billing, while also helping create a lower cost, more rational healthcare system for all Americans. This legislation deserves strong bipartisan support. I don't know if, okay, I'm going to yield back at this time. I don't think anybody wants to.
Gentleman yields back. The chair recognizes the gentleman from Oregon, the ranking member of the full committee. Mr. Walden.
Thank you, Madam Chair. I want to thank you and Dr. Burgess. I want to thank my friend Chairman Pallone as well, as we've all worked together on this. As I said in my opening statement, I'm proud to have introduced the No Surprises Act with Chairman Pallone. The title says it all. Patients should not experience surprise billing, but it's because of this market failure between hospitals, doctors, and health insurers that Congress is being forced to intervene. As you know, when we had the hearing last month, a mother sat in this very room, and she shared her family's heartbreaking story about receiving an unaffordable surprise bill. Sonji Wilkes, her son Thomas, born full term, just under 10 pounds in 2003, and as Sonji said, by all appearances, he was a healthy boy, but within a day they learned he had severe hemophilia, and when his blood would not clot following his circumcision, the hospital moved Thomas to the neonatal intensive care unit within the same hospital to receive close observation as well as an anti-hemophiliac clotting factor, which was administered by the hematologist. And unfortunately, Thomas and his mother Sonji, fortunately, Thomas and his mother Sonji were discharged within the normal postpartum period. And while the Wilkes family returned home grasping for answers to the unexpected diagnosis of this lifelong disorder, they never imagined what would come next, which was a $50,000 bill. $50,000 for Thomas's overnight stay in the NICU. $50,000 for one night's observation. Why? Turns out the neonatal intensive care unit, 50 steps from the delivery room, within the very same hospital, was out of network. Out of network. It's not right, it's not fair, it's deceitful, and if hospitals, doctors, and health insurers mean what they say, the patient should be held harmless, that patients are not responsible, then hospitals, doctors, and health insurers are responsible. And that's why we're here. Sonji's story teaches us two things. This is not a new problem. Her dreadful experience occurred 15 years ago, 15. And this isn't a small problem. A recent study found that almost 1 in 5 emergency visits results in at least one surprise bill. Chairwoman Eshoo, a quarter of the emergency visits in California, had a surprise bill. Dr. Burgess, roughly 40% of emergency visits in Texas had a surprise bill. These are not good odds, and this is why Congress is acting. Our bill is practical. Our approach is based on the principles of fairness and federalism. Here's what it does. Prohibits surprise medical bills. It holds patients harmless. It increases transparency. It empowers patient choice, and it makes a market-based approach dependent upon the location and type of care provided and indexed to provide certainty and prevent gaming of the system. Here's what it does not do. It does not establish a one-size-fits-all rate setting. This is a market-based solely on commercial rates and is dependent upon where patients live and the care they receive. This accounts for high-cost areas and low-cost areas and accounts for both rural and urban areas. Now, I do believe there are ways we can improve this bill. Drs. Burgess and Bouchon and Ruiz and others have raised really fair concerns with me and with others, and I look forward to continuing to work with Chairman Pallone to address the concerns that have been raised. But this is an intolerable situation that's going to get addressed either by states or us or both. And when my constituents, who fortunately have a protection much like this bill under Oregon law, have that protection, but if they were to get injured in some other state and run a risk of 1 of 5 or 1 of 4 or even greater odds, getting a surprise bill, that is unacceptable. When you play by the rules in America, you shouldn't get jammed. And I was on a hospital board. I'm not a physician, obviously, but look, this is going to get dealt with. And it's unfortunate it's in our lap, but it is. And together, we're going to make this happen. So we appreciate the open process we've had, Madam Chair and Mr. Chairman, in this committee. We've heard from a lot of people, and it's been, for the most part, very constructive input. But we're going to move forward. So with that, I yield back the balance of my time.
The gentleman yields back, and thank him for his comments. I want to recognize myself to strike the last word and speak on the underlying bill for a few minutes. As has been said, receiving a surprise medical bill is incredibly common in the country, with 1 in 5 emergency department visits resulting in a surprise medical bill. Now, we essentially are having to be the referees in this undertaking because we have the hospitals, we have the docs, we have the providers. We're taking the patient out of this. Patients have been screwed and tattooed with this surprise medical billing issue. So the patient is removed, and now we have to be the referee amongst the stakeholders. California, New York, several other states have state protections for out-of-network emergency patients, but state law cannot regulate the self-funded employer plans that cover about 100 million Americans, and that's why we're the referees here. It applies to ERISA. And without our taking action, millions of Americans are going to be left unprotected from this whole issue of surprise billing. So while I don't think our work is simple, I do think it's clear. We have to find a way to protect every American from a surprise medical bill. Patients deserve that. And I think, and this has been referenced, I think this means listening to any member from either side of the aisle who has a way to improve the bill. I think as we move forward, we need to strive for 3 core principles. First, and I said this before, we need to take the patient out of the middle. I don't think there's any question about that. Second, there can't be any loopholes resulting in a patient getting a surprise bill. How many, I'd like to count up the number of loopholes we have already closed this year in other bills. So we really have to have a keen eye in this and scrub it so hard to make sure that there aren't any loopholes and that what will happen, what can happen to patients would happen all over again. And members have raised concerns about possible loopholes. So there are changes to strengthen the bill to make sure that these are the best protections possible. We need to do that. Third, the payments that physicians received have to be balanced. If the payment is too low, there could be physician shortages and patients not being able to get the care they need. That's not an answer. If the payment is too high, the premiums could go up, and it would cost patients and taxpayers more. So I think that there needs to be, and I think we all recognize this, it's not just myself, there has to be a delicate balance so that patients will end up trusting that the legislation that we finally pass will protect them from the high costs and the surprises that they're subjected to now. And hospitals, doctors, insurance, and insurers have to pull their fair weight in this thing. You just do. We're doing our best to balance all these interests out. But you know what? Altogether, you created the problem. So now it's on our lap. We're the referees, and people have to pull their weight. If doctors are charging inflated rates, then they have to come down. If the insurers aren't negotiating with the doctors fairly, then there needs to be an enforcement mechanism to bring them to the table. If insurers save money from our bill, then those savings should be passed on to patients in the form of lower premiums. Hospitals have to take responsibility too, because they pay the physicians to practice in their facility. If they don't get enough doctors to staff their hospital, then they need to pay the doctors more. You know what? It's all about money, friends. What's news around here? And no one should profit from our bill. Not insurers, not doctors, not hospitals. So I want to thank each member that has worked very hard on this because it's not as simple as the title of the bill. And the only people who should benefit from our work really in the last analysis in terms of clear benefits are the patients. No one has a crystal ball to predict, I don't think, at this stage of the game, the best solution. What states have taken on, both California, my home state, New York, they haven't been at it very long. They really have not been at it very long. So people point to data. The data is really rather thin right now. California's benchmark payment approach has only been in effect for 2 years. New York's baseball-style arbitration, well, that's longer, that's 4 years. But I don't think the long-term effects are really so clear right now. So we need to continue our work between the subcommittee and the full committee, and I'll work again with anyone and everyone to get this thing right so that we end up in the Rose Garden and not looking in the gate, but being inside, so to get it done. And with that, let's see, on the Republican side, Dr. Bouchon is recognized for 5 minutes.
I move to strike the last word. First, I'd like to thank Ranking Member Walden for working with me on ideas as it relates to this legislation. Thank you very much. I made some comments in my opening statement, but I'll add to that briefly. I want to again say that a benchmark rate without an independent dispute resolution process will have unintended consequences. I've already spoke about the threat of narrow networks and contract cancellations, but I am concerned about the impact that this could have in the future of value-based arrangements. For example, MACRA put Medicare on a path toward rewarding physicians for value and away from fee-for-service. And this focus on value has been adopted in many cases on private insurance side as well. This proposal threatens value-based arrangements potentially because the worst physician and the best physician would be paid the same, and it provides no incentive for health plans or providers to negotiate around value. I also believe that consolidation in the healthcare is a significant driver of cost, contrary to popular belief from many. But I do believe that. But without protections for physicians, you will continue to see physician groups selling their practice to hospitals in order to stay in business because they simply can't sustain independent practice. And there has been some concerns about IDR, or independent dispute resolution, but Georgetown University Health Policy Institute Center on Health Insurance Reform did a case study on the New York surprise billing law, and as of October 2018, IDR decisions have been roughly evenly split between providers and payers, with 618 disputes decided in favor of the health plan and 561 decided in favor of the provider. And also concern about a cumbersome process or cost. Well, in New York, it's completely online and it costs $300. So again, I want to reiterate, I believe that without an IDR process in some form, and I'm flexible on that, obviously, that I'm concerned that for physicians it could be a race to the bottom on reimbursement. It could limit patient options to see a physician of their choice with limited networks. And I'm worried about implications in rural areas. I represent a rural district where it's difficult already to attract physicians. I would encourage everyone to read the AMA's letter that was sent to Chairman Pallone and Ranking Member Walden on this issue. It's fairly thorough. And I look forward to working with Chairwoman Eshoo, Ranking Member Burgess, Chairman Pallone, and Ranking Member Walden to come to a solution that, number one, protects patients, but also ensures fair payment for the provider and for the health plan. With that, I yield back.
Thank you, Doctor. The doctor yields back. On our side, who is next? Mr. Butterfield? No. Mr. Butterfield?
Thank you very much, Madam
Yes,
Chair.
you are recognized for 5 minutes.
I ask to strike the last word, please. Madam Chair, I agree with you completely. We must find a solution to surprise medical billing, and so I'm going to support this legislation fully. Patients should not have to worry about receiving an extremely expensive bill because they received out-of-network care during an emergency or from out-of-network providers at an in-network facility. But I do want to go on record today by expressing concerns, and these are the same ones that I expressed the last time we talked about it. I'm concerned about the potential negative impacts on rural access to care. And Dr. Bouchon's comments a few moments ago, I want to fully associate myself with those words. Much of my district is rural. In recent years, we've seen a reduction in local access to care. I've heard from providers in my district over and over again who are really concerned about the approach that we are taking. And so I want us to do a deep dive and to make sure that this legislation will not have a negative impact on rural hospitals. And with that said, I yield back.
The gentleman yields back. Someone just call my name?
Madam Chairman.
Yes, the gentleman from Illinois, Mr. Shimkus, is recognized.
Thank you. I asked to strike the last word. And thank you. And I'll be very, very short. I love this debate. It's bipartisan on both sides of this issue, which is good. That's why we eventually do things every now and then. And I think it's very, very healthy. Look, I'm an arbitration-style guy. I got on the bill. I think that's the way to go. Illinois has been doing it for 9 years, so it's not short-term. It seems to work in Illinois. And I just want to go on record that as we move forward, I hope we can get there where we have a product that we all can be unified on and not split. With that, I'll yield back my time.
Thank you. The gentleman yields back. Who's next? The chair is happy to recognize the gentlewoman from California, Ms. Matsui, for 5 minutes.
Thank you, Madam Chair. I move to strike the last word. Surprise bills for unexpected out-of-network care saddle too many patients across the country with financial stress. This legislation, the No Surprises Act, takes a vital step forward to protect patients from costly surprise medical bills. When you fall and break a bone, when you get into a car accident, your first thought isn't, am I in network? When patients need immediate care, they should not be held responsible for billing disputes between doctors and insurers. That's why I'm supportive of a common sense solution to prohibit providers from balance billing and take the patient out of the process of payment negotiations. I thank the committee for working with me to create a more predictable, transparent payment rate for providers and requiring greater transparency of insurers' provider directories. I believe the updated bill before us today is an improvement in our ongoing efforts to solve the problems associated with surprise billing. That said, we need to have further discussion about how to ultimately resolve the issues with provider and insurer payments. I've heard many concerns from doctors and hospitals in my state over the past few weeks about their experience with California's similar surprise billing law. While California law and the bill before us today aim to target a specific market failure, we must recognize the broader impact federal action may have on access and cost to the healthcare system. I believe in this committee, and I believe that by working together we can create an array of meaningful and fair solutions that consider all of the unique aspects of our healthcare system. For example, caring for patients in highly specialized and higher acuity settings comes with different challenges, and I'm interested in pursuing ways this legislation can account for these differences. I also think we should take a look at an appeals process for providers to be able to dispute a benchmark rate when appropriate. I look forward to working with all of you, as well as stakeholders, to continue to provide feedback that improves this overall product. In addressing the problem of surprise bills, we can not only protect patients, but also make a positive impact for our healthcare system. Thank you, and I yield back.
Gentlewoman yields back. The chair recognizes Mr. Bilirakis from Florida for 5 minutes.
Thank you. Thank you, Madam Chair. I move to strike the last word. I'd first like to thank Chairman Pallone and Ranking Member Walden for the important bipartisan work that you and your staff have done to protect patients from surprise billing. I'm in complete agreement that patients should not face crippling medical bills from out-of-pocket providers when they receive emergency care or in non-emergency care situations where the patient had no opportunity to select the provider. I understand the need for some a baseline rate for negotiations. However, there must also be some additional framework or fallback measure for providers to negotiate fair and adequate rates with health insurers. If providers, and especially providers of emergency care, who are obligated by law to care for every patient regardless of their ability to pay, are so disadvantaged in their ability to negotiate fair and adequate rates with insurers, their ability to continue to stay in business and to stay independent from large health systems will be jeopardized. We all agree on the need to protect patients from surprise medical bills. However, we can do so in a way that stays true to our free market principles and avoids potentially severe unintended consequences for patients' access to emergency providers. Chairman Pallone and Ranking Member Walden, thank you again for listening and providing an open process to members and stakeholders. I'd like to continue working with you between now and the full committee on including some sort of appeals process or backstop. I believe this would further improve the bill, and I yield back my time, Madam Chair. Thank you.
Gentleman yields back. The chair recognizes the gentleman from New Mexico, Mr. Lujan, for 5 minutes.
Thank you, Madam Chair. I move to strike the last word. This markup is examining a critical issue impacting my constituents and other individuals across America living in rural communities. I've heard too many stories of patients falling victim to surprise medical bills. Just last month, a Kaiser Family Foundation study found that 18% of all emergency visits and 16% of an in-network hospital stays resulted in at least one out-of-network charge, leaving patients at risk of unexpected medical bills. In New Mexico, that risk jumps to 29%, almost 1 in 3. These bills and surprise costs can have catastrophic impacts on families. The No Surprises Act takes steps to protect patients by prohibiting balanced billing for emergency services and prohibiting balanced billing if a patient does not receive adequate prior notice of the provider's out-of-network status. Additionally, this legislation includes a provision in this legislation that increases transparency in the air ambulance billing process. Now, this is a good first step toward addressing the issue of air ambulance surprise billing, but I'm confident more can be done. And I'm eager to continue working with Chairman Pallone and Ranking Member Walden on strengthening this provision before full committee markup, and I'd be happy to yield to the chairman or to the ranking member if there's anything that they might add on this as well. Mr. Pallone?
I'm certainly willing to continue to look at this transparency with air ambulance billing, and I do appreciate the fact that the gentleman raised this in a significant way at the legislative hearing, because it is something that we need to be concerned about.
I appreciate that, Chairman.
Yeah, would the gentleman yield?
I would yield.
Yeah, as we discussed earlier, happy to continue the conversation. This is obviously a complicated matter, but we're more than happy to sit down and continue to work on it with you.
I appreciate that, and I would yield my balance of my time to gentleman from Massachusetts, Mr. Kennedy.
I want to thank my colleague. Just very briefly, I'm going to reiterate some of the comments here from our colleagues. Thrilled that we are addressing an issue that has had devastating consequences for so many people across our country. Patients, under no circumstances, should be left with a devastating medical bill that comes out of surprise. They've got to be held harmless. We've got to find a way to strike the proper balance here. Look forward to working with our colleagues here to try to iron out some of the final details so that we can accommodate some of the concerns that members have addressed or members have raised to make sure that we do the right thing, and I'll yield back.
That I yield back.
I thank the gentleman, and I want to echo something that Mr. Pallone said. It was Mr. Lujan that really cast the spotlight on the extraordinary costs relative to this issue, to air ambulance. And it's is an important spotlight that he cast on it, and he questioned well, and I'm glad we're going to keep grinding this one out between the subcommittee and the full committee. Is there anyone on the Republican side? The gentleman from North Carolina, Mr. Hudson, is recognized for 5 minutes.
Thank you, Madam Chair. I move to strike the last word. And I want to thank you for holding this important markup, and thank you to the chairman and ranking member for introducing legislation to protect patients from surprise billing. I have constituents back home in North Carolina who are being caught off guard with large medical bills from providers they did not know they were involved in their procedures or did not have the opportunity to choose because of an emergency situation, and that is not right. I'd like to associate myself with the comments of my colleague, Dr. Bouchon. Doctors are the backbone of our medical care. It is no coincidence that the best quality healthcare system in the world has the world's best doctors. I've long believed that care decisions should be made between patients and their doctors, and that any interference in that relationship draws us further away from optimal care. However, healthcare is not purchased in the same way other products are, and doctors are not trained to treat for cost. They're trained to get their patients better as best they can. Insurance networks are an effective tool used to keep costs down, which can be a good thing. But oftentimes, situations beyond the patient's control force them to use out-of-network providers. This could be anything from an emergency room visit with an out-of-network surgeon or a scheduled procedure with an out-of-network anesthesiologist. Currently, there's not a meaningful pathway for insurers and physicians to resolve a payment dispute if out-of-network care occurs, and therefore the patient is left holding the bag. We need to take the patient out of the middle and leave resolution of payment to the physician and the insurance company. While this legislation is a positive first step, I do have concerns that while the policy is written today is good for insurance industry, it punishes providers. We need to balance this equation and provide an outlet for disputes instead of setting one price for health markets. I hope we can continue to work together and find common ground that will continue to protect patients. I look forward to working with my colleagues on this. I thank you, Madam Chair, and I yield back.
The gentleman yields back. The chair recognizes the gentleman from Vermont, Mr. Welch, for 5 minutes.
Thank you. I strongly support this legislation, but I have a few questions I'd like to address to council to make certain that the situation we have in Vermont won't be adversely affected. We in Vermont have an existing law in place. It prohibits balance billing in emergency provider settings, and the law further allows providers and insurers to negotiate a fair rate of compensation while holding patients harmless. And I've heard some concerns from the Vermont hospitals about whether this legislation will affect what their arrangement is. And I have two questions. First, would the No Surprises Act preempt Vermont's balance billing law?
Sir, it would not preempt current or future state laws.
Can you speak up so we can hear you, please?
Sir, it would not preempt current or future state laws.
Thank you. It's reassuring. And second, would the No Surprises Act allow Vermont to build on its own method of determining how providers and insurers resolve out-of-network payments for plans regulated by the state?
Yes, it would allow the state to come up with its own method to resolve that payment. On page 16 of the bill in subparagraph H, it states that that payment could be determined by the state law.
Okay, I thank counsel, and I yield back.
Gentleman yields back. Anyone else from the Republican side? The Democratic side, who's next? The gentleman from California, Dr. Ruiz.
Thank you. I would like to thank all of the members who have been working diligently on this issue, including Chairman Pallone and Ranking Member Walden. I appreciate that you have a very difficult job, and I appreciate your leadership in addressing this critical consumer protection issue. This is a complex problem with a variety of potential solutions, and while there are details that we may not all agree on, we are all on the same page that we need to end the practice of balance billing and holding patients harmless. The bill that we are considering today achieves those goals. However, we do have differing ideas about how to resolve the payment disputes between providers and insurers. The bill that Mr. Bouchon and I have introduced will, for example, allow providers and insurers to be able to appeal a payment dispute for unanticipated out-of-network care by using a voluntary, independent dispute resolution process. And this bill is modeled after a law that has been in effect in the state of New York since 2015, and 4 years of data, enough data and enough time to have statistical analysis coming out of there shows that it is working. I have concerns with the underlying bill as a one-size-fits-all approach to a system that is more complicated than that. Each patient and case is unique and may include variables that do not take into account in a flat rate reimbursement system. And we want to ensure that we get this process right and that whatever solution we land on doesn't have unintended consequences. And I am concerned over the potential negative effects on network adequacy, access to care in rural and underserved areas, and staffing issues at a time where physician shortages are already hurting our communities. States have been implementing a variety of solutions, and they have been the laboratories on what works and what doesn't. And while what we are seeing out of New York is promising, what I am seeing out of my own state of California is not. In 2016, California also set a benchmark rate, and we are getting reports back that insurers are canceling long-term contracts or demanding significant rate cuts to match the benchmark rate, jeopardizing patient access. Ultimately, we are working towards the same goal here, for patients to be protected from surprise bills, from inadequate network, and from rising costs. And I truly believe, I genuinely and authentically believe that we can work together to achieve that goal. So, Mr. Chairman, I'd like to ask you a question.
Sure.
Will you continue to work with Mr. Bouchon and myself in the coming days to work on a solution together?
Absolutely. I know you have ideas, and we've had discussions about how this problem should be solved, and I'm more than willing to listen to your ideas and the ideas of any members of the committee. Now, the ranking member and I have had a very transparent process on this issue. We released our discussion draft 2 months ago, requested feedback from the public, and held a legislative hearing where all the major players on this issue could have their say. But I understand you have your own proposal, and we've had, as I said, many discussions about it. Ideally, I'd want to get to a place where all members can be supportive of the committee's surprise billing legislation when we get to the full committee markup next week. But, you know, I think you understand that we can't be expected to throw away our bipartisan, bicameral solution. This is the one issue, really, where on both sides of the aisle, both the Senate and the House have said that we need to get something done and that we can. And the president, as you know, had his Rose Garden about a month ago where he said that he wanted to do this too. So I need to be certain that we have a solution that would not increase healthcare costs. Otherwise, this won't happen. So let me just say I'll continue to have an open door while we move to the full committee, and we'll have further discussions.
What makes your openness and your willingness to work is what makes you a great chairman. And also I appreciate the ranking member for really working with you on this matter in a bipartisan way. I truly believe that that our greatness in this committee is when we're willing to just listen to each other, work out our differences, and come up with a piece of legislation that all members here can fully and wholeheartedly support, and that will definitely be a reflection of your great time as chairman. So I appreciate that.
I heard Ms. Eshu tell us how great Mr. Soto was, and now Mr. Ruiz is telling me how great I am. So I'll say you're great too. I love you.
He should save telling you you're great until he gets after he negotiates with you. What a gentleman. The gentleman.
Just looking forward to a fair, benchmark and independent.
I mean, all kidding aside, the time between the subcommittee and the full committee, there's got to be some. It's got to be some real serious negotiation, and everybody that's involved in it needs to assume responsibility for that. Now, who's next? The gentlewoman from. Is it your side?
It's their side, but no one is.
No one on the Republican side. The gentleman
Madam Chair, I
from,
believe we
yes.
have, and we have votes on the
We
floor
do.
now.
We do. But we want to wrap this up because we don't have any amendments, and I think that we can, well, I'd like to not have to, the floor knows? The floor knows that we're here, so let's wrap this up. The gentlewoman from New Hampshire, Ms. Custer.
Thank you, Madam Chair, and I will be quick. I'd like to strike the last word. Thank you, and today's markup is a true testament to the important work we're accomplishing on the Energy and Commerce Committee. This legislation in front of us today is paramount to improving access to care and lowering out-of-pocket health costs for patients, whether it be prescription drugs or surprise medical bills. My home state of New Hampshire has been a leader on the issue before us today, ending surprise billing. I commend what we have done in the Granite State to take patients out of the middle, and I'm pleased that we've come to a bipartisan agreement on this committee to protect consumers first. We've all heard the horror stories of patients being left on the hook with unexpected medical costs, even patients who have health insurance. All the while, insurers and providers throw up their hands, leaving the patient holding the balance bill. As we continue in our discussions today and the weeks to come, it's imperative we consider the implications in rural districts, districts that are already experiencing a strained healthcare workforce with many critical access hospitals and rural providers struggling to stay afloat. We should recognize the special circumstances in which these rural providers operate and ensure that we do not exacerbate the many challenges they face. I'm proud of the bipartisan work of our subcommittee. It's long past time when Congress protects patients first and starts putting an end to surprise medical billing. I thank Chairman Pallone for his support and commitment to advancing this legislation, and I yield back the balance of my time.
Gentlewoman yields back. The gentlewoman from Delaware, Ms. Lisa Blunt Rochester, for 5 minutes.
Thank you, Madam Chairwoman. I move to strike the last word. I am pleased that we are addressing surprise billing here in Congress. The stories we've heard from patients, in the media, and also in this hearing room are not only infuriating, but they're really heartbreaking. And it's time that we do something to help Americans who are now discouraged and even scared to seek care that they need because of a bill that might show up later. I thank the chairman and the ranking member of the full committee for their work on this legislation, which I believe will help address this problem. One concern that I've been hearing, though, is about network adequacy. And as we've heard here today, some of the stakeholders in my state of Delaware have told me that they're worried about networks of doctors narrowing, which would make it more difficult for patients to seek in-network care, even when they have plenty of advance notice. It's also likely that a disproportionate amount of the burden would fall on some of our most vulnerable communities, which already face a shortage of accessible providers. I'm pleased that this conversation is continuing, and I look forward to working with my colleagues on the committee to further explore and address this issue so all Americans can be protected from painful surprise bills, insurers and providers can continue to negotiate their contracts in good faith, and communities with unmet medical needs in Delaware and in all of our districts won't lose access that they have for the services they need. Thank you, and I yield back the balance of my time.
Gentlewoman yields back. Are there any other members that wish to speak? Seeing none, the question now occurs on forwarding H.R. 3630 to the full committee. All those in favor of forwarding H.R. 3630 to the full committee will signify by saying aye. Aye. All those opposed will signify by saying no. In the opinion of the chair, the ayes have it. H.R. 3630 is forwarded to the full committee. Without objection, the staff is authorized to make technical and conforming changes to the bills consistent with the actions taken by the subcommittee today. And I'd like to place into the record and ask unanimous consent to enter. Can I just say all these documents, or I have to read them out? I ask unanimous consent to enter the following documents into the record. Letter from the American Academy of Family Physicians, letter from the Association of American Medical Colleges, letter from the Children's Hospital Association, letter from the Friends of PCORI Reauthorization, letter from Genetic Alliance, letter from the American Academy of Orthopedic Surgeons, a letter from the National Multiple Sclerosis Society, letter from the California Medical Association and from the American Medical Association, letter from the Federation of American Hospitals, letter from the Physician Assistant Education Association, letter from the Alliance for Specialty Medicine, letter from the American Dental Association, letter from the ERISA Industry Committee, letter from the Association of Chief Human Resource Officers, letter from the American Benefits Council, letter from the National Association of Health Underwriters, letter from the AFL-CIO, a coalition from Families USA et al., statement from the Manhattan Institute, American Enterprise Institute et al. And without objection, so ordered. The committee now stands adjourned.
Good job.
Thank